Okay. You're going to have to listen to me talk for a few minutes. I know I'm standing in between you guys and Wendy Davis, so I apologize. I just really want to thank everybody here in attendance for our first two-day conference. We're focusing on maternal mental health today, focusing more on maternal substance use disorder tomorrow. We have such a great lineup. I told Wendy this morning, between her, Katie, Ilana, at the end, all of our breakout speakers, Delaney, I don't know what we're going to do next year. I feel like we've covered a lot. But anyways, appreciate you all being here. Just a few housekeeping items. I know we switched things around last year, so whenever we have our break or our networking session, that'll be in the gymnasium where you all kind of saw where the vendor village was. We have two breakouts. The breakouts there will be one breakout here in the morning and one breakout in the afternoon in the morning as well. And again in the afternoon. We'll have lunch provided around 11:30, coffee, some snacks, please help yourself. For any moms who might need a lactation room, come find me or Haley or Sani, anyone who's with Mission Motherhood. There is a lactation room upstairs in room 218. Another note for you guys, if we've gone digital with our agenda this year. So I did have the QR code if you need to know where to find that. It's on our website, www.missionmotherhood.org/events, and you'll find speaker info and our agenda for the 2 days. Another quick note, we are beyond grateful for our sponsors. This would not be possible without our sponsors. And a main sponsor that we've had this year to help bring in these amazing speakers is AHEC. So with that, they do request that participants who are healthcare providers, not students. I see a lot of providers, not students today. Nothing against students, we want you here. But AHEC has a survey that they would like every attendee to complete. So if you could please do that, it goes into their resources and as a part of our funding as well. So we appreciate your support in that. Final point is, I'm a mom and I just lost my thought. I don't know. You have me all day, so I'm sure I'll think of it. But again, truly grateful for you guys being here. If you have any questions, please feel free to reach out to myself, Haley at registration, or Sani, who is in the vendor village, and we'll help take care of you. Appreciate your patience this morning as we helped to get set up. So without further mumbling along, I am beyond honored to have Wendy Davis here. So I'm just going to get a show of hands of who is familiar with Postpartum Support International. Okay. Who is familiar, who has their PMHC? So, okay, awesome. So I'm going to do a quick plug. So Postpartum Support International offers a perinatal mood and anxiety disorder certification. Through the PSI Indiana, offers scholarships to pursue that. It's a two-day course, some testing. You guys are healthcare providers, you know how certification goes. But there are scholarships available, whether that's through the state of Indiana or like directly through Postpartum Support Indiana chapter. So please, if you hear Wendy, if you hear Birdie, and you're interested in receiving that certification, please stop by the booth, ask me. That's how I got started. But Wendy Davis, goodness gracious, she is the president and CEO of Postpartum Support International, a global champion for pregnancy and postpartum mental health, training providers and connecting families to the resources and support needed to have the strongest and healthiest start possible. Dr. Davis provides leadership and strategic direction to the network of PSI chapters and experts to PSI's mission, vision, and purpose. She oversees PSI's delivery of perinatal mental health education, support, and services to pregnant and postpartum individuals, families, and providers. Wendy began her career as a psychotherapist and became a specialist in perinatal mental health after recovering from postpartum depression and anxiety. She founded Oregon's perinatal peer organization, Baby Blues Connection, and believes that peer support and wisdom of lived experience is an essential part of recovery. She collaborates with mental health care systems, community organizations, and government agencies, and serves on a national advisory board providing expertise on policy and practice related to perinatal mood and anxiety disorders. Dr. Davis and PSI partner with advocacy and professional organizations to advance training, policy, and services. She leads the national PSI Mind the Gap initiative, which brings together a coalition of stakeholders to ensure perinatal mental health is a national priority. And I think we can all agree it needs to continue to be a national priority. It's just an absolute honor to have Wendy here, so I'll get out of the way.
Jennifer can do everything.
It's Evan.
Jennifer and Evan have it dialed in. Thank you so much. Let's see, I'm going back, Evan. This is Evan. Thanks. Oh, thank you. You're good. And I guess I should be talking into the microphone. It is my honor to be here. Can you hear me in the back? Can you hear me in the front? I'm short. We're putting this down. I'm really thrilled to be here. Thank you, Jennifer, and thank you, everyone, for just attending today. When you think about a keynote, you want it to be a call to action. You want it to be informational, but mostly I want it to feel welcoming to all of you. We've been talking a lot at PSI recently about how we connect with people. And a really wonderful thing that one of our employees said the other day is that she was really moved by the fact that while we have always said we want to be available at Postpartum Support International for everybody, what we really want is for people to come to the website, to a group, to a phone call, and feel like we're here for them. So the difference of coming, and being part of something that's for everyone and something that is for you has a different feel. And that's our aim. So similarly, I'm going to be talking to each of you about how you connect with perinatal mental health and how I do as well. So first of all, I'm hearing an echo. Are you? Then it's just me. All right, good to know. Did you know that the first Wednesday of May every year is World Maternal Mental Health Day? So congratulations, Mission Motherhood, and all of you for being here today. What we do on World Maternal Mental Health Day is globally raise awareness. So there are people, used to say tweeting, but we're not tweeting and we're not Xing either at PSI. So just singing and posting and shouting from the rooftops. What is maternal mental health? June is Paternal Mental Health Awareness Month, but this month, this is the month where we really, really are focusing on mom's mental health. And that means also focusing on the mission of PSI, which is not just postpartum, but through the whole vulnerable period of pregnancy, post-perinatal loss, and postpartum, which we talk about lasting at least a year, or as some people say, postpartum lasts until your youngest child is out of diapers and you can sleep through the night. So, sorry, we understand that could be many, many years, as it was for me. Here I go. Now I'm over here. So thank you so much. What I First, want to tell you is that, as you heard in my introduction, I was not intending to specialize in perinatal mental health. Well, first of all, the field didn't exist when I was in graduate school. Sadly, it's still not required in graduate school for psychologists or in medical school. It's not a required subject. It's not an available specialty yet. People are working on that. But I got my crash course in perinatal mental health when I found, sadly, that I was horribly depressed, extremely anxious after the birth of my first child. And I had already been a therapist for almost a decade. I specialized in depression and anxiety. I worked with lots of parents. When I had postpartum depression and anxiety, I didn't recognize that I was depressed. So I was a specialist in depression, like being a meteorologist in the middle of a hurricane and not recognizing it was a hurricane. Who do you look to when you're depressed and anxious and things are going badly? Where do you find fault? Where do you find cause? That's right, you. So I thought, mistakenly, that I had failed. I shouldn't be in this club. I wasn't meant to be a mother. And my baby might be better off without me. My mission is to have every single person who experiences that around pregnancy, birth, adoption, fostering, and loss understand what PSI's motto is. You're not alone, you're not to blame, and with help you will be well. I was so fortunate to have a support system and good care, but it still took me months and months to understand that I had not failed and to look back and recognize I loved that baby from the start, but I was depressed. I wasn't depressed because I had a baby. I was depressed and I had a baby. I was anxious and I couldn't eat. And it took actually a wonderful doula. How many doulas do we have here today? Thank you, thank you. We all sitting together, of course. We love you. My doula was the one who had no training. So those, how many people are at a perinatal mental health training for the first time today? Welcome. My doula had no previous training, but knew enough to say to me, I think you might have postpartum depression. At 5 weeks postpartum, she was the first person with midwife, with the OB, with friends and families and nurses all around, and home visiting in Oregon, where I'm from. She was the first person to ask me, and do you know what she asked me? Very complicated clinical question. Have you been depressed or anxious? That was it. So I want you to know before I start that I carry that mama with me every room I walk into, every place I go, every advocacy moment I have. She's with me. That mom who thought she failed and didn't deserve to be here. And having seen my, what we say in the field, PPD baby this weekend, a beautiful young man, knowing that I adored him from the start, but I want you all to understand something. The agony and the distress of a perinatal mood disorder is not that we shouldn't be parents, it's that we're yearning to find that connection and that love that's in there, but we're depressed. We're anxious. We have other mental health disorders getting in the way. What is your job? You'll find out, but your role is to help that person take the first step and then help them along the way until they're just walking. They're just moving. That's where this all comes from, and full circle. We love the full circle moments. Postpartum Support International, we provide peer support in English and Spanish every day for free to families. We provide trainings and all kinds of things. Chat with an expert once a week. And as Jennifer said, perinatal mental health certification. Visit the website, postpartum.net, and our helpline is 1-800-944-4PPD, 4773. Has anyone here worked on the PSI helpline before? Just checking. So this is fueled, spirited, and accomplished by hundreds of volunteers in English and Spanish. So when people can telephone, text, or send a web form to the helpline, and they get connected one-to-one with a volunteer who's going to welcome them, we're so glad you called. Tell us a little bit about what's going on, or texted. Give them information, basic information, not outside the scope of volunteers, because we're raising awareness, just like we're doing for diabetes. Right? It's the same kind of issue, like just here's the info that we want to share with you, then resources and referrals. Every message and every conversation is confidential. And the person, the help seeker, as we call, which is much easier to say in the 21st century than caller or texter, the help seeker has a choice about what to share. It's not a crisis hotline, and it doesn't handle emergencies. So you can see all over the website and in our greeting that we direct people to emergency services and the hotline, which I'll tell you about in just a second. When there's an immediate crisis, we direct everybody to 988, the suicide crisis and suicide prevention hotline in the United States. So what we talk about and what is represented in this room is integrating services. So the care of perinatal individuals and the prevention of crisis and distress requires, as Mission Motherhood says, a village. It requires a lot of steps on the chain and of support to create that safety net. So at PSI, we have the support, peer support referral network. We have an online provider directory, and then we have trainings for professions and of all sorts, including volunteers and advocates. And we have a national free psychiatric consultation line. How many prescribers are here today? Welcome. So Indiana has one too, which I'm going to talk about. But this is a national one for states where there isn't a state consultation line, and we are so, so gifted to have that available with a perinatal psychiatrist consulting to other prescribers. State resources. Go Indiana is what I have to say, because, and you see I have the convenient QR code. You may take a picture and go there yourself. And you'll also be able to find it easily on the internet. Every state has a PSI chapter, just one to unify the state. And what the chapter does is bring people together, anyone who wants to be involved in perinatal mental health in your state. Also, every state has local support volunteers. We call more and more often community navigators. So if somebody calls or texts the PSI helpline from anywhere, they talk to that person we talked about before. They are then referred automatically to a state support volunteer. And the chapter is kind of the convening of all that, the umbrella. So this QR code brings you right to the PSI Indiana chapter website. Anyone from PSI Indiana here this morning? Well, we're so fortunate to have Courtney Ginder as one of our PSI employees and a member of PSI Indiana chapter. So we're so glad to, I just love Courtney. So much of our social media is due to her giftedness. I'm going to just embarrass you for this moment. And then we have a provider directory, as I talked about, the psidirectory.com/Indiana. You'll find all of the providers in Indiana, and that's also free. How many folks here are on that directory? Thank you. Thank you. All right. The most effective states in getting things done and taking care of families have good collaboration and relationships with their departments of health. Again, go Indiana. The Indiana Department of Health is a major champion, has brought together scholarships, trainings, collaborations, advocacy for good legislation, and this is how things work the best, is when you have the Department of Health behind these efforts, you're really going to make progress. And the other thing that I mentioned is perinatal psychiatric access programs. And in Indiana, CHAMP, which stands for Consultation for Healthcare Providers in Addiction, Mental Health, and Perinatal Psychiatry Program. So tomorrow when you hear about substance use and abuse and recovery and prevention, remember that this CHAMP provides consultation for the whole gamut, mental health and addiction, specifically about prescribing and diagnosing. Anyone here connected to CHAMP this morning? Welcome. Are you glad to see this on the PowerPoint? I thought you might be. I think it's unbelievably hard to really get awareness of resources like this out. So I know how hard that is and how important it is. Do you see what I'm saying? The circle of support is what is going to save lives. And you have it going on here. So what I'm going to focus on is the known and the new and the known. The field of perinatal mental health is not new. It's not new. Over 100 years ago, people talked about this. And Bertie Gunyon-Meyer is going to talk in her breakout about the whole gamut of screening and treatment. What I'm talking about is where we are as a field, what's new, what's threatened, and what remains. So this slide represents what's new. In a way, does it represent what's threatened with changing federal priorities? I'm going to stand here as the federal contractor where we run this hotline for HRSA, for Health and Human Services, and say, I am confident that this hotline will continue despite changing priorities. And evidenced by that, this morning, Health and Human Services launched a social media campaign talking about the 3rd year anniversary of this maternal mental health hotline and making sure everyone knows about it in English and Espanol. So we're really, really, really proud of this. Imagine, this is just 3 years old. Health and Human Services runs this hotline because Congress voted it in at the end of 2020. At the end of 2020, this was legislated. So it's paid for by taxpayers. Thank you, everybody, and myself as well. And it's run by HRSA. That's Human Resources Services Administration that takes care, it really focuses on early childhood and perinatal support. Things like home visiting. These things are so important. Home visiting, research, pregnancy, research, health, and prevention. Why do I pause? Because we have all worked so hard for these resources and advocated so hard, and to have a hotline this pass through Congress and be funded by Health and Human Services, we want this. It should and does go hand in hand with state, county, local efforts, grassroots support, because the hotline refers people and is supported by all of these champions. And we know that public health funding, research, and home visiting, much of it has already been cut. So I pause because this is a really monumental moment. What's important here in this room? We're doing this work. We will continue to do this work, and we need more than ever to be able to connect with each other. So the hotline, 833-TLC-MAMA, 852-6262. What is this? 24 hours a day, middle of the night. You don't have to raise your hand, but do you remember how important it would have been, or maybe it has been if you ever contacted the hotline in the last 3 years, to have somebody, a trained, compassionate provider on the other end of the line say, we got you. We got you. You're going to be okay. We have testimonials both from the PSI helpline and the hotline that just make me weep when I read them. Staffed by licensed, by decree, by legislation that need to be licensed, but not just mental health, doulas, nurses, lactation consultants. We've had an OB work on the hotline, midwives, anyone who is credentialed, licensed, and has insurance. So you can find more information about that on the HRSA MCHB, Maternal Child Health Bureau, HRSA website. So now we're going to move into what are we talking about? So some of you are here for the first time, and some of you already are perinatal mental health professionals. I'm going to speak to people who are just coming into this right now and to say, first of all, there's 3 things to remember if you remember nothing else. Do you know what they are? And this QR code brings you to learn more about perinatal mental health. What are the 3 things? We used to call it PPD. Everyone's familiar with that term, right? Who's familiar with PPD? Used to be nobody. Now everybody knows, thank goodness. But then we started saying PMDs, which is perinatal mood disorders. Then we realized, what were we leaving out when we say perinatal mood disorders? Anxiety. Really importante. Like, so perinatal mood and anxiety disorders was PMADs. Now PSI is using PMHDs. Why? Perinatal mental health disorders. Because we were leaving out psychosis and post-traumatic stress disorder. So when you look at this whole beautiful graphic, you can see that we're talking about a whole range of disorders. Bertie Meyer will talk more about that. You can go to the PSI website, come to our trainings. But there are 3 things to remember, and I remember this when I'm talking to media, talking to first-time folks. And what are the 3 things when we think about postpartum depression? Which is the term people know. It's not just depression. Anxiety, post-traumatic stress, OCD, intrusive thoughts, bipolar disorders, and psychosis are all considered perinatal mood disorders. What's number 2? It's not just postpartum. Rates of postpartum depression and other perinatal mental health disorders, especially depression and anxiety, are just as high in pregnancy as they are postpartum. Did you know that? Just as high. So you don't want to wait till postpartum, let alone 6 weeks or 3 months later, to ask, how are you doing emotionally? You want to ask anytime you're seeing someone during pregnancy or postpartum, what's the worst that will happen? Is that pregnant person says, I can't believe they ask me how I'm feeling every time I see them. Is that a bad thing? It's really not. 3, it's not just moms. Dads, and the American Academy of Pediatrics was the first to do this research. Dads get postpartum depression 1 out of 10 at least. And the leading indicator is if mom is also depressed. Learn more at PSI. So what is new? What we have learned from CDC research in 2022 is the majority of maternal deaths are preventable. How can we know that? What we know is, and the reference is here, according to the CDC, 84% of pregnancy-related, so it's pregnancy and postpartum deaths, are preventable. But mental health, including substance use disorders, are the leading cause, not of morbidity, which is illness, mortality. Before this research was done, I want you to know something. There were no statistics. There was no data on maternal suicide. Lots of advocacy and lots of dollars and federal support went into the CDC uncovering this research. Do you know what sticklers they are there? They are really good researchers. I know because I've done a PowerPoint presentation for them. We really went through a lot. This is really important information. If we know that the leading causes of death are preventable and due to mental health and substance use disorders, what can we do? Prevent the morbidity and the mortality. We can prevent women dying. But even 5 years ago, I remember, because it was right at the start of the pandemic, I talked to someone who was doing this research, and she said, suicide's too hard to research. We'll never get it. And I was so disheartened. But then they did. DAP funding's been cut this year. We have advocates all over the country who have literally downloaded the data so we can continue. But we're not going to forget this. It's in all of our slide decks. We want this research to continue. We want this history of science to continue, but what we know is, we already know this. This won't stop our work, will it? We know that every step you take and everything you do is part of that prevention. So what do we also know is that despite the fact that up to 1 out of 5, at least 1 out of 5 women experience a perinatal mental health disorder, research again has shown us that only 1/4 of them seek treatment. What does everyone else do? They do what I did until someone asked how I was doing. If I didn't have support, if I was a single mom, if I was experiencing racism, if I didn't speak the language of my city, I don't know if I would have made it. And I'm not exaggerating. And I represent everybody. When you're depressed or anxious, depression, anxiety don't care who you are, where you come from, but your environment does add to it. And so we know why less than 25% seek help, don't we? What keeps a mom from reaching out? Shout it out. Stigma, fear. What is she afraid of? The baby will be taken away. And does that actually happen? Yes, it does. We can prevent that. So the other thing that data shows us is that maternal mortality rates, when you compare by race, these are the statistics, and it may be hard to read from there, but I want you to know that the highest bars across the country are for Black women. The highest rates of mortality, of death, related to pregnancy were Black women in 2018 and 2020. And the first one on the left is the total. In the littlest bar is 2018, then 2019, then 2020. The next section is white, non-Hispanic. The over-the-top, unacceptable high bars are non-Hispanic Black. And then the fourth one is Hispanic. So that was 2018, 2020. And then there was enough support and funding that they ran it again. 2022 and 2023, so recently, overall the rates decreased, but the discrepancy stays the same. And you might know that these exceed the rates of every developed country in the world, even when we had funding. And I do think that's stigma. And I think that's insurance, and I think it's Medicaid, and I think we've worked so hard to really improve this, and we're going to keep working on this. But look at this in 2022 and 23. Again, the discrepancy is even higher. So Black women are dying at higher rates for all the reasons mentioned before, but most importantly, for provider bias, racism, and lack of access. And so we just have to keep improving this. That is new information that's hard to hear, but really important for all of us to know. So what do we have? Last year, well, actually 2 years ago, a national task force, a federal task force was implemented, which was so exciting through SAMHSA, Substance Abuse and Mental Health Services Administration. And we got to be on, I got to sit on that task force, which was really exciting. You can find out more about it here. I don't know what the future of the task force will be. Again, we have a whole report here at this website, samhsa.gov. You can find the Maternal Mental Health Strategy report that came out of months of convening. And in their report, it won't be like news to you because I think you all know this, but how wonderful to have a federal task force pull this together. And they had people with lived experience, providers of all kinds, and governmental agencies. And they came up with this blueprint, the whole person dyad of perinatal mental health and SUD care right in the center. That's the center. And the center includes, again, you probably can't see it, so I'll read it to you. 1, to build a national infrastructure prioritizing perinatal mental health and well-being. Make care and services accessible, affordable, and equitable. And then the bottom one here, use data and research to improve outcomes and accountability. So this isn't a couple people saying, hey, this sounds good. This is literally I know, months and months and months and hours of convening and facilitated meetings and Zoom meetings and amazing people at SAMHSA and HRSA and Office on Women's Health who facilitated this. To have trauma-informed approaches, to be culturally relevant, and to have federal collaboration. I wrote a letter to Health and Human Services, RFK Jr. last month. I did. PSI did. Nicole Serino, our board chair, and I. And I just got a letter back yesterday. And they said thank you, and they're very glad to know about us, and will be sure to consult us in the coming months. So yay! Because I can say all this and not even tell you who I voted for. I'm just telling you, we as maternal mental health advocates, we've got some data, and we've got some mission, and we've got some goals, and we can all do this, no matter who you vote for, what your politics are. This is why we're here. And what's most important is that we are here for each person, each party, and we have information, and we have really good, solid facts to proceed. I was glad to get that letter back. All right, so peer support resources are at the core. I know this with all my heart, even if there had been treatment, medication, books, and websites when I had PPD, there weren't. If there weren't peer support, and there wasn't, you just still end up feeling kind of broken. What do we need as a community so we don't feel alone? So that's what peer support does. It says you are welcome, we are with you. So here's an example of all of our peer support, because pictures tell, a thousand pictures are worth one word? No, pictures tell the story. So we have online support groups, we have peer mentors, we have one-to-one volunteers, we have state support volunteers, and we have groups for dads. And within those online groups and volunteers, we have specialties like loss, feeding challenges, a group for Black moms, a group for South Asian moms, a group for dads, a group for LGBTQ+. So many, 100 groups, is that right? 100 groups. We started with 2 employees. I was the second one. And in 2018, we only had 8 employees, and now we have 80. That's what the pandemic did with PSI. We got really big and really busy. So I'm going to tell you the new about peer support. Peer support is ancient. We've had to revive it, right? The doulas know this. This isn't a new thing. This is ancient. This is how women should be giving birth, is within community. What's happening in the 21st century? First of all, yay, peer support being integrated into healthcare settings. So a healthcare provider could not only provide treatment, but say, here's someone for you to talk to. And that someone you talk to might be the person that gets you to have the courage to tell your healthcare provider the truth. Community navigation, and all of this with peer support too, improving access and cultural relevance and inclusiveness. Here's another really cool new thing. We are finally getting peer support into scientific research. We are involved now in a 6-year study, PCORI study, which is Patient-Centered Outcome Research Institute, where we're studying with amazing healthcare providers, the psychiatric access programs, what is the difference between usual healthcare with consultation with the psychiatric access programs? What happens in OB settings when you have that versus when you have that plus peer support and community navigation? Our hypothesis is that when you have peer support and community navigation through PSI or another support system like that, what happens after the healthcare provider says, you know, you should join a support group. Bye. Or, I know that there's some chapter here or volunteer, I think it's postpartum, I'm not sure. Providers want to do well, but if they don't know, they don't know. But to be able to say, here's a peer mentor I'm going to connect you with, and they're going to help you find the resources right here where we live, that's what we're studying in the research. So that's new in peer support. The second new thing I'm going to tell you about is the research on fathers' mental health. Who's hormonal? Turns out that dads also go through, not just, we already know 1 in 10 dads get depressed, but we, until recently, hadn't researched the physical part of that, not just the sleep deprivation, but look at this. There's a drop in testosterone. There's an increase in cortisol, the stress hormone. There's also an increase in estrogen and vasopressin and in prolactin, oxytocin, what we talk about being responsible for breastfeeding. And we often say it's the love hormone. But a lot of times postpartum, we end up feeling all that love because sensitivity, vulnerability, and exhaustion and biology can equal a mood disorder. So what happens with dads is not just environmental. And despite what people argue on the internet, dads do get postpartum depression. Here's another new thing. I'm just walking you through all the new things. Now, Bertie, if you want to learn more about perinatal mental health disorders, Bertie will talk about all the disorders, including postpartum psychosis, more in her breakout. And of course, you have a choice between lactation, information, lactation support, and the PMD 101. And you can get the PMD 101 online too, so I just wanted to give a shout out, your breakout. They're both gonna be amazing. I don't know which I would choose. But here's about postpartum psychosis, and right now I'm not going to focus on the whole disorder, but how many of you have heard of postpartum psychosis? Right, that's what's in the news. 1 to 2 out of 1,000 women. But for those of you who are PMHCs who already learned about this, I have to correct one thing here, which is that here are the new things we know about psychosis postpartum. We have been improved by listening and including people with lived experience and an understanding. They have wisdom that goes beyond textbooks and beyond what we have known for hundreds of years through academia. Women with lived experience of postpartum psychosis have changed the field. One thing we have learned is don't call it rare. Just don't. And if you do, correct yourself. I've done that. It's not a rare disease. I used to say that until I gave a talk to nurses. How many nurses are here today? Thank you, nurses. I gave a talk to nurses, and they're like, that's not a rare disease. Up to 1 in 500? That's not a rare illness. So don't call it rare. It makes people think the wrong things. It's less common than the other perinatal mental health disorders, but it's more severe. The other thing we're learning about is the relationship of bipolar mood disorders to psychosis. Really, really great research coming up around that. And the last thing I want to say is that we used to teach that, as I talked about, there's perinatal OCD, which includes intrusive, scary thoughts. And we have always said, if you're worried about them, it's not psychosis. How many people have heard that before? If you're worried about those scary thoughts, it's not psychosis. We have to stop saying that, because psychosis and women with psychosis also experience intrusive thoughts, and they are scared. They're very scared. The biggest issue about psychosis is it's waxing and waning. The symptoms rise up and they go away. When they're not in that florid psychotic state, they're very scared. So we have women who've gone to providers 8 and 9 times saying, I'm very scared, I keep having these thoughts, and I think I might be also having psychosis. And every provider said, well, if you're worried, it's not psychosis. So there is OCD with intrusive thoughts. That's anxiety disorder. And the difference is really clear. If you're not sure, you call PSI and ask them about it. Or come to one of our trainings and understand, while anxiety does have intrusive, repetitive thoughts that are hard to shake, if you can do an assessment, are there other times where you feel dreamy or she seems out of touch? Are you having bizarre dreams or daydreams or experiences? If the anxious woman's going to say, no, I'm just afraid, I've never been close to acting on this. But if you really assess and develop a relationship with the family or the person who's going in and out of psychosis, it's a different picture, but it can include anxiety. So we have discussion tools, another QR code for PSI, and we've had one for several years, one for anxiety and depression, perinatal mental health disorders. The one on the right has been adapted for loss. But the one in the middle is hot off the presses just last week, and it's a discussion tool for postpartum psychosis. So these are things that people can bring to their providers and use it as a basis to really improving the discussion. The other new things I will just slip through here. The role of medical providers in perinatal mental health care is really starting to change. We are all working together there. Technology has improved our ability to reach people and be reached. PSI now has an app. It's called Connect by PSI, available on Google Play and the App Store, free and English and Spanish, completely translated. So we have apps, we have databases, telemedicine, thank you, pandemic, that really increased access, online support. What about chatbots? We're not ready for that. We tested a chatbot. It didn't have the nuance and the safety net that our volunteers had. We like to use AI for analysis, but just so you know, not for the one-to-one. But do come find our app. What the app does is just point you to the resources. So what's happening nationally, I'm just gonna say before I finish, we have to stay at the table. If we, all of us, with our voices, aren't at the table, the default, which is okay, it's just not everything, is to talk about either maternal health, so the physical issues that cause morbidity and mortality, Or just talk about mental health generally, general population. Who talks about maternal mental health? If we're not there, really nobody. So stay at the table, stay in the conversation, get your information. We do have risks of federal cuts to programs. We have to keep an eye on that and do our best to raise our voices with all respect to all people. We have to keep the safety net alive, and Medicaid is really part of that. So when you're looking at Medicaid, Medicaid is people's insurance. This is how you get your medical insurance for birth. Do you know that more than 50% of all births in the United States are Medicaid is the insurance for that? So, lastly, when you hear all this and you go to these beautiful breakouts for the next 2 days, you will feel overwhelmed. Here's what I want to share with you. This is my favorite question I ask myself, and I use to train our volunteers and providers every day. Instead of saying, oh my gosh, what does she need? There's so much. What can I do to help this family? Ask yourself this, take a breath. What is my role? What is my best role in what she needs right now? This is also very good for parenting. Not how can I do this? I can't. What is my best role here? Versus what else can I do? And then you find who else can help you with that. Find the next place where you get that resource. Just do your best work. And I tell you, I say that to myself probably 10 times a day. And I ask my employees and our volunteers that too. To understand your stress and triggers, those are real things. So take a breath, take a walk, take a break. Watch Top Chef, whatever you do. Just do that thing that makes you breathe and has your body know you're not at war. There's no tiger chasing you. What are your resources? Where do you reach out for support? Please think about this and take these seriously. Where do you get information? You can really, we're so thrilled when people come to postpartum.net and just look it up and call us. That's what we're there for. Also, know how many of you provide actual emergency crisis services? Thank you. And the rest of you, everybody else? Thank you. If you don't provide crisis services, the best thing you can do for yourself is know where yours are. 988 nationally, but you have them in Indiana. If you don't know right now, if you think, when I go back to work, what if someone was in an acute crisis? If you don't know, do that first thing when you go back to work, write it down so that you can say, my most important role here is to help them get to crisis prevention. So that's it. To maintain and sustain this work comes from inside first. What helps you feel renewed? There's a lot of debate about binge watching, and I think the consensus is, while it's fun, it is not the same as renewal, but it is fun. What really helps you feel renewed? And it doesn't necessarily take a long time to get that renewal. How do you create time for yourself? And what are the challenges? And for me, that's how we all will continue to save lives and prevent escalation of crisis. These are so many things we can prevent. This means all of us working together, because we deserve that growth in this field, but most importantly, new families, pregnant, birthing, postpartum, post-loss families struggling will feel better, and they won't feel lost, and they won't feel like they're out in the cold. So this is everything here. Collaboration, gather the facts, write them down. You don't have to, if you're not good at memorizing, write them down, and when someone says, well, how often does this happen, and why is this important? Look at your notes. People in Congress do this all the time. If you watch them, they're always reading. It's acceptable. Many of them. Listen to and include stories of lived experience. Find your champions. How many people work in hospitals here? Thank you. That's a champion. You are taking time out to be here. We need you. Legislators, county health departments, families, funders. Thank you, AHEC. Stay in touch with each other. Don't give up. Understand that competition is a natural feeling. There's nothing wrong when you feel competitive, or why'd they get that? Why'd they do that? Move past it. Move past it to collaborate. To say, hey, let's have a talk. Let's have coffee. Let's do this together. Remember that small conversations lead to big steps. Just like for the pregnant or postpartum mom who's struggling, what I needed to know when I was that new mom is I just had to take one step. My midwife finally, when I told her, finally said, you will get better, Wendy, but you have to take one step. But if that's all then I took the next step. And now look at me. Small conversations lead to big steps, and acknowledge and celebrate everybody you can, every time you can. Not just the new parent, but also your fellow providers, and they're sitting here, right here. So contact information, I am happy to hear from you, I really am, and I'm so glad that you're all here today. So thanks, Jennifer, again for inviting me and PSI.
All right. Can we give another applause for Wendy? Would we be in this room without Wendy? I don't know. And the work and everything that people have been doing for the past, years. So very much appreciated. So it looks like we're going to go right into our breakouts. We have Birdie Gunyon-Meyer, who's going to be in here doing Maternal Mental Health 101. And back in the gymnasium, we're going to have Katie doing lactation and mental health. Really hard choices. We'll give you guys about 5 minutes or so to get some water, coffee, mingle, and we'll get back to our breakouts.
I'd go see Katie. I'm surprised they got anybody in the room. Okay, I'm in trouble. I haven't even put it on a jump drive yet. It's on my laptop, but okay, just give me a second because I'm talking in the mic so everybody can hear me. It's okay, I'm not saying anything bad. Where's my mic? There it is. Yay. Okay, everybody ready? Who's never heard me speak before? So some newbies. Who came back to hear me again? Welcome back. No new jokes. Maybe some new jokes. Hey, I would have gone to hear Katie speak on lactation too if I wasn't speaking. So anyway, that's going to be a good talk, but I'm going to have a good talk too. So here I am. As you can see here, first of all, I am born and raised Hoosier, Frankfort, Indiana. Hot dogs, go hot dogs. And you want to be really impressed? I was inducted into the Hot Dog Hall of Fame last year. Thank you. Didn't even know it existed, did you? Not unless you're from Frankfort, Indiana. So anyway, I went to Indianapolis to go to college and met my gorgeous husband and fell madly in love, and orchestra played when he walked in the room, for real. And anyway, I ended up staying. I live now in Speedway, Indiana, home of the Indianapolis 500, the greatest spectacle in racing. And it is May. And it's so funny because somebody just said to me, oh, I'm going to PT right now because I messed up my back and sciatic nerve and all that stuff. And my physical therapist said the other day, yeah, well, race weekend. And I said to him, fun fact, no one else but Hoosiers say race weekend. See, in any other state, any other place, we say Memorial Day weekend. But in Indiana, or especially in Indianapolis, we call it race weekend, race day. So it's a big thing, and I live 3/4 of a mile from the track, so you know my house is hopping. Everybody parks in my yard, and no, I don't charge them. It's all friends and family. So I worked at IU Health for 1,000,000 years, and in 1997, someone came to me and said, do we have anything for postpartum depression? And I said, no. I'm an OB nurse with a master's in counseling. Let me look into it. So I started a program. I ran it for 25 years. I retired from there in 2018. And God bless you. In 2000, I went to Walnut Creek, California to take training from Postpartum Support International because I knew nothing, zip, about perinatal mood disorders. So I went there, started volunteering, started getting more and more involved, became the first chair of education and training on the board of directors for PSI. Then I was a president, and then I continued with education and training. And then Wendy and I met in 2005, and we started doing stuff together. And then when I was collaborating, and then when I was president, somebody gave us big bucks and got Wendy hired as our first executive director. And at that point, we had one staff member, an admin, who answered the phone and ran the office, and Wendy was our very first employee. And then I just started working on curriculum and doing all kinds of stuff, and Wendy and I were planning trainings together. It was crazy. We were doing it all. And we're so cool now. We're so big, and we're so blessed to be this big. So we've watched it grow over the years, and I continue now work full-time as the Director of Education and Training for Postpartum Support International, and assume I will never retire. So I keep getting asked, are you going to retire? No, I don't know. I guess I'll know when it's time, but it's not time yet. I also set up the certification program. I heard Wendy call me out several times, shout out to me. So I got to live up to the shout outs now. Here I am. So I'm a nurse. I'm also a therapist. I started out as cardiovascular critical care and ended up in OB, lactation, childbirth ed, did all the OB stuff, fell in love with OB. I am on the Maternal Mortality Review Committee for Indiana. And I think I've told you everything else. I find it an honor to work in this field, to meet women, birthing people, postpartum people and their families, and help them get help and get better and find a way to wellness. And it's amazing, really. Every other program I've ever started in my entire career, I would take it, build it from the ground up, pass it on to someone else. This program I never could give away. I can't leave it. It just, once you're here, and so many people have changed careers literally after having a perinatal mood disorder themselves, then they're like, I'm going to work in this field. So I see it all the time, which is fun to watch. So anyway, if 1 in 5 to 7 women and 1 in 10 men get a perinatal mood disorder, this could bring up feelings. This is content warning. It could touch you. I'm going to give facts, right? You want to hear facts about what this really is. Did you find this clicker worked at all, Wendy? No, not working. Oh, yes it did. This is PSI. It's the vision of PSI. Every woman and family worldwide would have access to information, social support, and informed professional care to deal with mental health issues related to childbearing. We promote this through this vision through advocacy and collaboration, and by educating and training the professional community and the public, which is what we're doing today. It's pretty iffy on this forward clicker. What do we need? I heard Wendy shout out to the doulas. I always shout out to the doulas. Where's my doulas? Are they in here? Yay. Okay. We all need a companion or an advocate to provide support during pregnancy, birth, and the first year postpartum. You only get that with a doula. And let's hope that the day is going to come soon that doula care will be paid for, because we know doulas make a difference. I mean, by insurance. You know what I'm saying. We need supportive professionals who are knowledgeable about mental health. We need all of our OB care providers, nurses, therapists, psychiatrists, family practice, pediatrics. They all need to know what a perinatal mood disorder is, and we still aren't there yet. They say that they should be screening all of those organizations, but it's still not happening. I set up a screening program at IU Health at all 15 hospitals statewide, and people always ask this question, well, is this the best time to be screening, Bertie, at 2 days postpartum? Well, no, there's no research that that's the best time to be screening, but nobody else is doing it. We should be screening and educating every time we cross the path of a pregnant or postpartum person and partner, if they're coupled. But we're not. And so we've got a captive audience in the hospital. Most people deliver in a hospital. So we've got them all. And the ones that don't deliver in a hospital are delivering at home or in a birthing center, and usually those people are educating and screening. So let's get real. So no, it's not the best time. I just went to Madison, Wisconsin last week and trained a hospital up there, all the bedside nurses, to know how to screen and how to educate. And this is a quote from our president and CEO, Wendy Davis. It's only a piece of paper. That screening tool is only a piece of paper. If you're not educating, if all you're going to do is hand them the Edinburgh Postnatal Depression Scale, score it, and put it in the electronic medical record and not say a word to them about what the outcome was, or where to get help, or if they're pregnant and they feel fine right now, what to watch for, what are the risk factors, what are your risk factors, then you've wasted your time and their time. Don't bother. Please don't give a screener if you're not going to educate or do anything with it. And do you know how many people come to me and tell me, oh, they screened me. They screened me all through pregnancy. Every visit, they handed me that tool and I filled it out, and I know myself. I looked at it and saw it was high. No one ever mentioned it to me. What? So we've got to, every time we cross the path, we've got to be screening and educating. And we just still don't have that universally yet. And we need a time and a place to talk about pregnancy, the birth, and the continuing postpartum experience. It's the #1 medical complication of childbearing, and I will show you more about that later. ACOG says, the American College of Obstetrics and Gynecology says, we know we've outlined what are the risks when we don't treat. We have all these problems, relationship problems, poor adherence to medical care, exacerbation, IPV, loss of finances, disability, unemployment, child neglect and abuse, developmental delays, behavioral problems, more nicotine, more smoke and weed, more alcohol, more just basically more behavior of self-soothing. And I've had people tell me, well, my OB wouldn't give me an antidepressant, said it wasn't safe, so I have to smoke weed. It's the only thing that calms me down. It's the only thing that helps my nausea. I also have people say, Bertie, you asking me, telling me that it'd be good for me to go on an antidepressant is like asking me to put a foreign substance in my body. And I said to her, you just told me you smoke weed. And she said, oh, but it's from the earth and natural. Right? So that's some of the stuff we're up against. And then the worst outcomes of not treating a perinatal mood or anxiety disorder: infanticide, homicide, and suicide. Suicide comes from hopelessness. I'm never going to be myself again. This is who I am now. This is who I am going to be forever. If I'm going to be like this forever, I'd rather be dead. They'd all be better off without me. We have to give hope. You're not alone. This affects 1 in 5 to 7 women, 1 in 10 men. You're not to blame. You didn't do something wrong. We've got to teach it's not just about hormones. It is about risk factors. And you might have a bunch of them. Sorry about your luck, right? How many in here are normal or come from a normal family? Anybody? Come on, raise your hand. Yeah, I didn't think so. Here's what happens at my family get-together. At my family get-together, I lean over to my cousin and I say, you know what, ain't none of us right. And she laughs and says, I know, some of us worse than others, but ain't none of us right. On my mother's side of the family, we all inherited this big, long history from her mother's side of the family. We know where it came from. But it's lots of depression and lots of bipolar. And then I married a guy whose family history is bipolar, schizophrenia, substance use disorder, OCD, intrusive thoughts. Oh, my side also has substance use disorder. So do you think my girls got out of this without a diagnosis? No. They got to inherit all that good stuff. You also got to inherit what you have. So quit acting like you're going to go for a run and it's going to be gone, right? Don't do that thing like, well, it's okay if you take medication, but I don't need it, because I know what to do. It's okay if you go to a therapist, but I don't need a therapist. What's with that stigma that we have, right? Our head is attached to our body. Notice this, head attached to body. Why is it when I go in for my first prenatal check, you would never say, Bertie, I know you got high blood pressure, but let's get you off that blood pressure medicine and hope you don't have a stroke. Would you say that to me at my first prenatal visit? Would you say, listen, Bertie, let's get that pancreas to kick in a little better and get you off your insulin? Because we want that baby to be in a natural environment. Doesn't that sound just silly? But we do say every day, to some poor person who's got well controlled with her SSRI for 5 years for her panic disorder, or someone with bipolar disorder, well controlled, we say, let's take you off those meds because we want that baby to be healthy environment and have no medications. We just told you that we'll treat your physical ailment. We'll treat it. We don't expect you to make it work, but we expect you somehow to buck up and make your anxiety, your depression, your bipolar just go away without medication. We have over 45 years of research showing research in medication during pregnancy and lactation. Don't you think we've got enough research to show what's safe in pregnancy and lactation? We do. Prozac's been out for well over 45 years, and Zoloft's been out, I don't remember how long, but I remember when it came out. We've got lots of research. Quit saying that it's not safe, or we've got the research. Okay, that's enough. Wendy already talked about the CDC and what came out from our maternal mortality review committees. And for years, people would come back from conferences, from my nursing conferences, allergies. They would come back and tell about, we heard all about all the #1 reasons for maternal mortality. And they would talk about all the physical things, preeclampsia, hemorrhage, hypertension. And I would say, what about postpartum depression? What about, I don't know, nobody talked about it. For years, we didn't act like it was even an issue, like that even caused it. Now what do we know? 36 states, consultation of 36 states of maternal mortality review. Finally, the word is out that I've known for years, and that is #1 reason, mental health issues. And what goes right along with it? Substance use disorder, also with mental health issues. So we can no longer ignore it when it's finally there. Now you see all the other reasons, physical reasons, and we do need to pay attention and all of it, but we need to quit ignoring the fact that the #1 reason is mental health. And Wendy already said 80% of those can be prevented. At the end of each case we talk about death that we talk about in our committee, we will say, could this have been prevented? What could have been done differently? And we also ask, was this caused by racism? Okay, look how many we find. We find about 50% of them during pregnancy and about 30% postpartum. Look who goes on to get treatment. Hardly anyone. You know why? We hand them a card when they come in and they say, if they have the nerve, because if we don't ask them how they're doing, they're not going to tell us. And if they do, we say, well, here's a card. Here, call Bertie. They leave there and they think, I'm so embarrassed. I shouldn't have this. Oh, I'll wait. I bet this will go away. I won't call. Or they have phone anxiety, right? Or we give them a 10-page piece of paper with all the people that take their insurance here. Here's a bunch of therapists who take your insurance. They call the first 3 and they find out we're not taking new patients. I'm exhausted. I'm depressed. I'm not calling any more places, so I don't get any help. So, as Wendy said, you heard this, we call it perinatal mood and anxiety disorders, we call it perinatal mental health disorders. With our patients, with our clients, we call it postpartum depression. If they're looking for help, they're Googling postpartum depression. Don't call it perinatal mood and anxiety disorders with your clients because they don't know what it means. My Uber driver doesn't know what it means, okay? If he says, what are you in town for? Construction conference, because I'm not going to tell. I had the nerve to tell it yesterday, and oh my gosh, you get to start hearing all the problems of them and their family, and you're just like, I didn't really want to work in the back of this Uber today, but it's okay. But if one time I did say, well, I work in the field of perinatal mood and anxiety disorders, and the driver said, is that PTSD? I'm like, yeah, kinda. So just don't. Just say postpartum depression. And when I say I work in the field of postpartum depression, everyone says this, oh, that's a real thing, isn't it, Bertie? Yeah, it is. So what's the prevalence? 80% of us get the baby blues. 1 in 5 to 7 mothers experience serious depression. 1 to 2 in 1,000 have postpartum psychosis. And you already learned not to say rare, just less common. And 1 in 10 fathers. So there's ACOG and their posters. No matter how much money you have or how many resources you have, this can affect anyone. Serena Williams said, not only was I accepting some tough personal stuff, but I was just in a funk. Mostly I felt like I was not a good mom. When we use the word postpartum depression, it means it's only in the postpartum period and it's only depression. So what have we done for years? We've taught this. If you find yourself crying a lot, be sure and call your doctor. Well, what if I wake up mean as a snake? What if I'm screaming at my toddler, screaming at my spouse? I don't know what I have. You didn't tell me to watch for that. What if I wake up jumping out of my skin, anxious? I don't know what I have because you told me to watch for crying. Most people, if you say to a crowd of people, what is postpartum depression? They'll say, crying all the time, or I want to kill my baby. Andrea Yates drowned her 5 children in 2001 in Houston. And other horrible incidences like that have happened since. And when it happens, it's all over the news. And the newscasters say they think it was postpartum depression. They think it was postpartum depression. So what happens is everybody walks around saying, I don't have that. I don't have that. And I'm not crying. So I don't know what I have. We think it'll go away on its own. We think it doesn't happen during pregnancy because it's postpartum depression is the term we hear. And again, we talked about physical versus mental, right? All of us got this stigma right here. And if you haven't noticed, we just now call it postpartum. You notice this? Hope I don't get postpartum. My sister got postpartum real bad. One woman said to me, Bertie, I got postpartum so bad I got it during pregnancy. Let me think about what you just said. I had a news reporter say, can you tell me the difference between postpartum and postpartum psychosis? And I said, well, first of all, we got to have a word after the word postpartum. That took 5 minutes to explain. So remember, the postpartum period is from the time the baby is born through the first year. That is the postpartum period. It's okay if you call it postpartum. I just want you to know you're going to hear that more and more. When people say postpartum, they mean postpartum depression, most always. So what are our myths? We have myths about getting pregnant. It's going to be really easy or really hard. People say, I was told I could never get pregnant because I have polycystic ovarian syndrome. I was told I could never get pregnant because I have endometriosis, and I just had a one-night stand and I get pregnant. Is this some kind of joke? Well, I don't know who told you could never. They might have said it might be difficult. So we have myths about becoming a parent, about being pregnant, about labor and delivery, about breastfeeding. The perfectionists, and you know who you are, I'm not one of them. Your house, your life was always in order before having a baby, and all of a sudden the baby comes and, whew, it's chaos. You can't keep it together anymore. The perfectionists really suffer. Those of you who have children already are nodding and laughing with me through this. Those who still want to have children, I'm sorry that we're going to scare you this morning. I don't mean to, I just want to tell you the truth. We think we're going to be happy all the time. How about the couple that says, we've been having a lot of issues, but we're going to have a baby to draw us closer together? Oh, I don't think that's a good idea. No. You argue about things you never argued about before when you have a baby. You never even saw that coming. Everybody in the media has a baby bump and skinny legs. Everybody. This is what you see. I never had skinny legs. I still don't have skinny legs. And when I was pregnant, I was big, 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 big all over, all over. And I went to the grocery store at 4 weeks postpartum, guaranteed I was still big, all over. And the cashier said, "When's your baby due?" And you don't know whether to laugh or cry. Yeah, she's at home with my mother-in-law, but whatever. No, here's what you have to learn. Do y'all know this? You never ask someone if they're pregnant unless you see crowning. That's it. It's the only way you ever do it, okay? Because once you've said it, it's out there. You have said, "I thought your belly was big enough that I thought you were pregnant." So, and you can't take it back. It's out. No matter how many "I'm sorries" you say, it's out there. So, a lot of myths, right? See all these different myths that aren't always true. So what's it look like entering motherhood? Right here. This is it. When we are pregnant for the first time, we are absolutely no idea, clueless about how our life's about to change, and this is what we think it looks like because this is the images we get. Now, I use friends and family. Now, I don't know her. She's kind of a stock image, but I use friends and family all through this, and you will see, and I have their permission. But this is the image we all have, right? This is what it's going to look like. It's just going to be looking at our sweet baby, our baby cooing back at us. Everybody's standing around, everybody's smiling, everybody's happy. There's no crying babies here. And we have this image that we're going to put the baby in their little bassinet, we're going to make dinner, and then our partner's coming in the house, and we're, "Hello, dear. Hello, dear, dinner's ready. Let's eat." Yeah, those babies don't breastfeed all through dinner, do they? No, they leave us alone. They don't cry. No, the reality is you're in football hold while you're eating a bowl of cereal. That's as good as it gets postpartum. But that is not what we thought. So in our lives, we have different seasons. And when we have seasons of giving in our lives and seasons of receiving. And when you are a brand new parent, you're in the season of receiving. And we have to keep saying that over and over and over. We think it's weak to ask for help. We think we should be able to get it together and do it all by ourselves. And the truth is, we need help. And we used to have, in former generations, everybody gathered around and helped. We also have certain communities, such as the Mormon LDS community, the Amish community. They all gather around and help take care of the other kids. They help with the house. They bring food. They let that new mom just take care of their baby. And in other cultures and other countries, they do the same thing. But most of us here in the U.S. are doing our own laundry at 4 weeks postpartum. And we feel embarrassed to ask for help. I always say over and over, you've given before. You have. Remember how good you felt when you gave? You will give again, but right now you're supposed to be receiving. When I'm pregnant, it's all about me. The only thing I'm thinking about is me, me, me. And I'm decorating the nursery, and I'm going to childbirth ed classes. And I'm learning how to push and breathe, and I don't think 1 second beyond labor and delivery and pushing and breathing. You think back before you had a baby, that's all you thought about. I teach a 4th trimester class for IU Health. It's free, by the way, for anyone who's pregnant and wants to take it. And I have those little smiling pregnant couples in there listening to Birdie tell them about how to get ready for new parenthood. And I try, but they always come back, "Why didn't you tell us?" I did. You couldn't hear me. All you were thinking about was pushing and breathing. And all you were thinking about was, what color are we going to paint the nursery and what cartoon characters? Why do we somehow think that we're going to know everything immediately as soon as that baby's born, but we don't realize it until this happens? And I can't tell you how many new moms have said to me that while they were holding that baby, right there in labor and delivery, they said, "Uh-oh, I know nothing." They used to say to me when I worked postpartum and walked them out in the wheelchair, "Bertie, you're going home with me, right? Bertie, do you realize that I don't know what I'm doing?" That panic, you remember it? That panic you feel if they're sending me home and I know nothing. You did prepare for labor and delivery. You read all there was, but you didn't think about this moment. And you think you're going to have mother's intuition, parents' intuition. You know nothing. You just met this baby 2 days ago. You don't know what her cries mean. You don't know how to comfort her. You know nothing. One woman that came to see me said that they were out on 465 going home from Methodist Hospital, and she said to her husband, go back to the hospital. And he said, did we forget something? And she said, no, you have to take us back. We don't know what we're doing. And he said, honey, they're not going to take us back. And she said, I just burst out crying and said, they have to take us back. Like, I don't know what she thought, she was just stay there for like 6 months. I don't know. But it was that panicky feeling of, I don't know what I'm doing. Now the baby's here. It's not about me anymore. Now the focus is on the baby, forming an attachment. And not everybody falls madly in love with their baby right away. You don't put that on Facebook, do you? Hey, y'all, you told me I was going to fall madly in love with this baby and feel gushy and all. I don't feel it. I'm not feeling it. You don't put that on Facebook. Everybody lies on Facebook. They're lying on social media, right? What are they saying? They're saying like, happy anniversary to my best friend. We were married 15 years ago today, and you're the best father and the best husband anybody could ever ask for. These are people in my family who hate each other. And they are at our family get-togethers arguing, screaming. And so I like walk up and I go, you guys doing better? No. I'm like, well, what's all that jazz on Facebook? Oh, Aunt Bertie, everybody does that. Oh, I get it. So you know what? Many of my clients said they got off social media because it looked like everybody else had it together except them. They're the only one who didn't know what they were doing. None of us knew what we were doing. None of us know what we're doing. We are fatigued, we are sleep deprived, and if these new postpartum people, new mamas, had the nerve to say it, and they do sometimes, they say, what about me? What about me? I don't know what I'm doing. My perineum hurts. I'm not catching on to breastfeeding. Help me. Overnight, you lose all your freedom, all control of your schedule, and you don't know what you're doing. So all your freedom. You don't get to come and go as you please anymore. You don't say, I'm going to run to the store. Yeah, with a baby and a diaper bag and a change of clothes for both of you. You lost all control of your schedule. Your schedule's your baby's schedule. You don't go to sleep when you want, eat when you want, do nothing when you want. And you don't know what you're doing, so your self-esteem plummets. When you are pregnant, when we are pregnant, our estrogen and progesterone are as high as they're ever going to go. When I deliver, those crash down, up come oxytocin and prolactin, brings in the love hormone, brings in my milk. That's what causes the baby blues. Remember I said that. That's what causes baby blues. That's what everybody thinks they have is the baby blues. Hormone changes peak at 3 to 5 days postpartum and cause baby blues. That is not postpartum depression, which everybody says, I had the baby blues for 6 months. No, you didn't. Baby blues last 2 weeks at the most. That's a teaching point. Your baby blues only last 2 days to 2 weeks. When it's beyond 2 weeks, something else is going on. The birth may not have gone as expected. You're learning new skills. We taught you how to change a diaper on a plastic doll. We did not tell you that baby was going to poop all the way up to the back of the neck, did we? Or pee in your face. We should do something like that in childbirth ed class. Just shoot off something while they're changing that plastic doll. We're learning new skills we never knew. This is one of the hugest role transitions in your life. You are redefining yourself. You're a parent now. You're parents together if you're coupled. You're a mom. You're a dad. Whatever name you go by. I love to see people right after they've had a baby, I love to just walk up and say, you're a dad. And they say like this, I know, I can't believe it. Right? It's shocking. It's a redefining. Once you're a parent, you can never go back. You're not ever not a parent again. Like one of my moms said at group one week, like, how's it going? And she goes, I don't want to do this anymore. I want to go back. I don't want to be a parent anymore. And I'm like, we all kind of laugh, because at group, you're allowed to say whatever you want to say. She said, I want to get up on a Saturday morning, smoke some weed, and watch cartoons all day. I said, well, you can still do that. You need a babysitter. Ain't going to work with the kids. So we're redefining ourselves. Hugest role transition in your life. When my husband died, I had to redefine myself as a widow. Weird word, it is. It's just a weird widow. And single. You're facing fears and feelings, renegotiating. Who's doing all this work? Who's making dinner? Who's going to the store? Who's dropping off at daycare? Who's picking up at daycare? Who's taking the day off when the kids are sick? The things you didn't think about when you were all starry-eyed, right? You're establishing feeding, you're insecure about what you're doing, and you are physically and emotionally healing from labor and delivery. So never thought about losses, the word loss, around a beautiful new baby. But like I said, lots of freedom, control, self-esteem, body image, career potential, money. It's not how good of a mother you really are, it's how good of a mother you appear to be on Facebook. So let's look at the meat of what I want you all to know. Perinatal mood and anxiety disorders can be depression, anxiety, panic, OCD, PTSD, psychosis, and bipolar. These disorders can affect us at any time in our lives, but when we are pregnant or postpartum, they are ramped up and they look different and feel different. So let's say I already had a history of anxiety. Now that I have a baby, my anxiety is about a baby. Or when I'm pregnant, it's about this pregnancy. During COVID, anxiety was out the roof, right? Totally. So, largest study to date, Catherine Wisner and other reproductive psychiatrists found a study of 10,000 women. Now keep in mind, most research has been done on white heterosexual couples. So when I use the word mom or dad, the study has said that. And this study was done on 10,000 moms. Women. And what they found was 21% had postpartum depression. To break it down, 1 in 7 developed it during pregnancy, 1 in 7 in the first 3 months, 1 in 5 when they carried this study out to 1 year. So that's where you hear that 1 in 5 to 7. What did we find with diagnosis? 68% had unipolar depression or just plain old depression. What went right along with it? 66% anxiety. Those two hang out together. Depression and anxiety like to hang out together, but many times you'll see a presenting factor of anxiety and you don't see maybe a little depression, or you might see depression. So when we only told them to watch for depression or crying, we're missing those people that are jumping out of their skin and worrying. 22% were diagnosed with bipolar disorder, and 19% endorsed thoughts of harming themselves. Now, just what I said earlier, the changes in hormones at delivery causes the baby blues, which peaks at 3 to 5 days. Overall mood is happiness. This does not last more than 2 days to 2 weeks. We find this in 50 to 80% of anywhere that we've done research in any country. We find 50 to 80% of new postpartum women get baby blues. If it's beyond 2 weeks, please give us a call. And we've got to be able to inform offices that when someone calls and says, I think I have postpartum depression, that someone on the phone, front office, doesn't say, yeah, welcome to motherhood. Right? We've got to listen. One woman said, they told me call back if it gets worse. How bad does it have to get before I can call back? Don't do that. Okay, let's look at depression. It is sadness, crying, overwhelmed, possibly suicidal thoughts that this is me, I'd rather not be here. So we've got to ask about suicidal thoughts. Typically with depression, not always, but typically overeating junk food, sugar, and chocolate, oversleeping, and still when I wake up, I'm exhausted. I want to just escape into sleep. I'm not brushing my teeth. I'm not taking a shower. I don't want to see you. I want to isolate because I don't want to have to pretend that everything's lovely and okay with this new baby. I can't even function. And this is where it comes of they're taking care of the baby and that's about it. They can't do anything else. And irritability and anger can be a part of depression or anxiety. And we didn't tell them, I'm telling you, screaming at toddlers, screaming at spouse, screaming in traffic. Oh, I do that, wait a minute. If everybody just knew how to drive as well as I do, we wouldn't have problems, would we? And tailgaters, oh, tailgaters. Yeah. Anyway, enough of that, irritability and anger. This is like if Irritability and anger is the same feeling as that PMS before periods, and where you just, but it's really rageful, they'll say. And they'll say later, after I speak at women's groups, I didn't know that was part of a perinatal mood disorder. Gosh, that's what I had, or that's what I still have. And what they'll say is, I really, when I was raging, felt justified by what I was doing. And later I looked back and had to apologize because I acted so horrible. They feel guilty and ashamed, hopeless and helpless. I'm never going to be myself again. Bertie, I shouldn't be in your office. I have a healthy baby, a wonderful spouse, a beautiful home. Why am I in your office? This is so embarrassing. I'm so overwhelmed. If I'd known it was going to be this hard, I wouldn't have had a baby. If I'd known it was going to be this hard, I'd have waited 5 more years, because you think you're going to be smarter in 5 years, and you're not. We already talked about not everybody falls in love with their baby. Anhedonia, what is that? Loss of interest, joy, or pleasure in the usual activities I used to enjoy. Suddenly, I don't care about anything. Hey, why don't I watch the baby and you go out to dinner? You love going out to dinner. I don't want to go out. Hey, you know what? You love your pottery class. Why don't I watch the kids and you go to pottery? I don't want to go to pottery class. I don't care. It is a sense of just no joy, interest, or pleasure. This just doesn't feel like me. People don't wake up and say, hey, I think I got postpartum depression. They wake up and say, I haven't been myself since the baby was born. This just isn't me. Something's not right. So listen for those things, people don't really think they have postpartum depression, but some of that's from the fact that they don't really know what it is. So we looked at depression. Let's look at anxiety. Agitated, can't sit still, worry, heart pounding. I cannot eat. The thought of food makes me sick. I'm vomiting in the shower. And you run into these women, and they have lost 20 pounds in 2 weeks, and people say, look at you, got your figure back. No, they got anxiety. They're calling the pediatric office every day. They got anxiety, okay? They cannot eat. They cannot fall asleep. They cannot stay asleep. They can't go back to sleep. The question is not, are you sleeping when the baby sleeps? That's like asking, are you doing laundry when the baby does laundry? Right? It doesn't make any sense. But if I say to you, if your baby slept for 4 hours, just straight, would you be able to sleep? Those who are anxious say no. And then I say, why not? I can't shut my mind off, Bertie. I'm worrying all the time. And there's too many things to do. I mean, the dishes need done, and the laundry needs done, and the house is a mess, and I've got to take the dog for a walk. I can't do all this. And so my mind all the time with the constant, I got to watch the baby. What if she stops breathing? So that's really the question. Would you be able to sleep if the baby slept? Constantly worrying, racing thoughts, short of breath, heart palpitations. Then I go into a full-blown panic attack. My heart's pounding out of my lips go numb, my face goes numb, my hands go numb. I have chest pain. I think I'm having a heart attack. I end up in an emergency room thinking there must be something wrong. I'm dying. And I get told, no, this is postpartum anxiety. Panic, you're having a panic attack. Does everybody know you don't send somebody to emergency department to get treated for postpartum depression? A lot of people like, send them to ER, send them to ED. No, they're not treating them. Do you know this? Unless they are suicidal, emergency, or in a state of psychosis, and those two things are medical emergencies, and they will probably be admitted. Other than that, if you send somebody with postpartum depression to ER, they're sitting around with all the heart attacks and everybody else getting triaged, and then they finally get seen and sent home without any medication. They're not medicating them in emergency department. That's not their follow-up physician. They're still going to say, call your OB in the morning, and the OB office is the one who sent them there to start with. So this runaround is exhausting. But these people with panic disorder, panic attack, show up in emergency department. They're given a benzo, okay, to calm them down. They calm down, and they get told, call your OB in the morning. That's it for treatment. Once I've had a panic attack, I panic about having another panic attack, and this is how you'll hear a panic attack described. I thought I was dying, I thought I was losing control, and I thought I was going crazy. That's exactly how you hear it. Okay, OCD. You're so OCD. What's that mean when I say that to you? It means you're all neat, everything's in order, right? We throw that term around, you're so OCD. But if you truly have a diagnosis of OCD, it is debilitating. It gets in the way of your living, and it's the most misunderstood of all of the perinatal mood disorders. So, classic symptoms of OCD that we all know: cleaning, checking, counting, ordering. And we all do some of these things, right? But if I've got truly an OCD diagnosis, what happens when that baby's born? First of all, don't touch someone's baby without asking. What is that about? When strangers come up and rub their hand on your baby's head. Oh, don't let her. The people with, I don't want you touching my baby anyway, and I don't have OCD. But if someone has OCD, you just contaminated their baby. They are horrified. They can't wait to get away from you. They rip all the clothes off their baby. They wash their baby down from head to toe, and they are shaking because they're so afraid now their baby. They have a lot of contamination fears. They can't come to support groups. They don't want anybody else touching their baby. And even if you work in this field, and like, let's say you're in anything, and you, like, let's say you work on the postpartum unit, you should still say, hey, I'm going to check your baby, okay if I pick her up? Ask permission, but don't ever touch anyone else's baby without asking. Just don't do it. So I've got all these cleaning. I can't let you help me around the house because you don't do it right. I have to redo it anyway. I can't let you do the laundry because you don't fold the towels right. People will say, oh no, he offered to help me, but he won't do it the way I told him to, because you have to vacuum the living room first and then the family room. And if you do it backwards, it's not okay. And I'm like thinking in my head, come vacuum my house anytime when you want and do it however you want. I don't care how you fold my towels either. But I don't have OCD. If you have OCD, this is a real thing. Counting and order. So cleaning, checking, counting, ordering. And this is the other way it looks. I clearly saw my daughter gray and dead under the water. I couldn't give her baths or take her swimming or put her anywhere near a body of water. What kind of mother thinks these things? My daughter would have been better off without me. These are recurrent images, thoughts, impulses. They come out of the place in our brain that wants to protect our baby, taken and twisted and said, what's the worst that could happen? And then you have images, pictures, a movie playing in your head. What if, what if, what if? These are our what if thoughts. Now, 88% of new parents, both parents have what if thoughts. What if I drop the baby is a really common. Another common one, which is interesting to me, but I hear it a lot, is what if someone breaks in my house and steals my baby? But some of these what ifs have triggers, and they're very vivid images and are horrifying. And they are recurrent, persistent. Like one woman said, I get up to brush my teeth and here they come. Images, pictures, movie playing, story I'm telling in my head over and over. Then I do things to stop. So let's say I have the thought, what if I drop the baby? Then I get to the top of the stairs and I think, oh, what if I fall down the stairs? What if I throw the baby down the stairs? You start having these, oh. And so you sit on your behind and you bump down the stairs. So it gives temporary relief until you get near a height again, and then it starts all over. Now, remember, 88% of us have the what if, as both parents. But either parent or both parents can have OCD diagnosis, and when they do, these are horrific images, thoughts. So they are intrusive, repetitive thoughts, usually of harm coming to baby. They're caught in this what if thinking. They have tremendous guilt and shame. One of our colleagues said, why can't I have thoughts of rainbows and unicorns, but instead I have to have these horrific images? There are certain triggers. They engage in behaviors to avoid harm. So I'll give you some examples here. Here's some just thrown out, all the different thoughts. Here are major triggers in perinatal OCD intrusive thoughts. Hear me again, the most misunderstood of all the diagnoses. If someone tells this intrusive thought to the wrong person, uneducated in perinatal mental health, they will call CPS, DCS on them. They will send them to inpatient psychiatry thinking they've got psychosis. These are what ifs. So what are common triggers? Some of you have them, right? Some of you are having more of them right now just because I'm talking about it. Some of you have never heard of this, saying, I have never heard of this. And some of you are saying, ooh, I've had these my whole life. I didn't know what they were called. Okay? So, these are common triggers. Heights, banisters, stairs, any kind of height. Water, driving over a bridge, giving the baby a bath. Sharp objects. Traffic. Sexual thoughts. So what do? I take all my knives and scissors and I lock them in a lockbox and I put them in the back of the closet, because every time I get ready to cut a tomato in the kitchen, I keep having this image. What if I, no. It's a really horrific, vivid image. They can't drive over bridges. They won't give the baby a bath. They won't drive in traffic, because guess what? Tailgaters going to be tailgaters, and I've got a baby in the back seat now facing backwards, and you are so close to my car, and I want to scream, get away from my car, get away from my car, I got a baby back there, and I have a panic attack and have to pull off the side of the road. Sometimes the very most shamed of the thoughts are when I am changing the baby's diaper and have sexual thoughts. Imagine telling this to the wrong person. That's usually the last thought they'll tell. Those are intrusive thoughts. They are not going to do these things. Heights, sharp objects, water, traffic, sexual thoughts, and actually, if you have intrusive thoughts, it's almost anything you can imagine. So, I'm going to give you all an intrusive thought. You're driving down the highway, you're behind one of those trucks with the cars chained up on it. What's going to happen? They're all coming off. Every one of those cars is going to hit you head on, and you know it, and you get out from behind it, right? I have a lot of intrusive thoughts behind a pickup truck with a bunch of stuff in it that's not bungee corded down good, and there's always a mattress in that pickup truck, and you know that mattress is coming out. You know it is. We see them all over the interstate. I was on 465 not long ago when a mattress flew out in the middle lane, landed right there in the middle lane. I was in the right lane, and I spent 5 miles having this conversation. Oh my gosh, if I had been in that middle lane right behind when that mattress came out, it would have totaled my car. I might have really been hurt. Oh, I would hate if my car was totaled. I love my car. I'm not ready to buy a new one right now. I don't want a car payment. Gosh, that's going to be a pileup in that middle lane. I hope no one gets hurt. How are they going to get that mattress out of the middle of that without someone getting hurt? This went on for 5 miles. I don't have OCD. But that is, can you imagine brand new baby and you really have OCD? You have this nonstop movie playing. So here are common OCD presentations: fears of deliberate harm, contamination, lots of contamination. You wash the baby's bottles with bleach, and now every time you get ready to put milk in the bottle, you're like, what if there's still bleach in there? What if I poison my baby? So lots of, I touch this, what if that contaminates my baby? So you see all these. The gold standard for treatment is exposure and response prevention. It's a form of CBT, but it takes extra training and knowing what to do. Don't send them to someone who does not have training in perinatal mood disorders, and especially don't let them go to someone who read 1 chapter on exposure. They need to be well trained in this. And again, we have a directory, psidirectory.com, and you can go on there and hit Indiana. You can even put in Fort Wayne if you're right here in Fort Wayne, wherever you are. And you're going to find all the therapists that are trained, and you can specify ERP. Or you can put in OCD, and you find those people that are trained in OCD. Those who are not trained in this area, do you see how they can mess them up? Do you see how they'll send them to the wrong people? They'll turn them in. I've had women tell me stories over the years of being at the OB office and telling them about their intrusive thoughts, and the next thing they know, the police are coming in because the office has called 911 to have them taken to the psych unit. This has happened more than once, I just want to tell you. We must ask about scary thoughts, and the way you do it is say this: you know what, sometimes new parents have scary or unusual thoughts. Are you having any? And this is a real common one. Yeah, I'm afraid my spouse is going to leave me and I'm going to be all alone to raise this baby. Yeah, that's common. What if something happened to me and my baby would be all alone without me? But if they go like this, I can't say them out loud, they're just so awful. You know they've got intrusive thoughts and they're starting to they don't want to say them out loud. And you just say, yep, I know what they are, you can tell me. Now, at support group, we don't let you say your intrusive thoughts out loud. We say, when it's your turn to talk, you say, I have intrusive thoughts. But if you have intrusive thoughts and I have intrusive thoughts and then you start giving yours, I'm going to get all yours too, and I don't want yours. I got enough of my own. So we also say I had a traumatic birth. We don't give details. That is what you do with a one-on-one therapist or with your doula, someone who's trained, that you can actually say, listen to these awful thoughts I'm having. So you need to be comfortable listening to these thoughts. So as Wendy just told you, and I'm going to emphasize, OCD thoughts, they are low risk of harming baby. Thoughts are not actions, they're thoughts. The parent does not have delusions or hallucinations. They are in touch with reality. So you're checking that. And again, you can call the hotline and say, I don't know if I'm looking at OCD, intrusive thoughts, or psychosis. I don't know what to do. When they have psychosis and the thoughts are high risk, that is when, yes, the thoughts still might scare them, so you can't say, do the thoughts scare you? Because that's not a way to do it. It's, are they hearing things or seeing things that aren't there? So example, one of my clients called me one morning and said, Bertie, last night I was holding the baby, and his eyes started glowing, and I thought he was demon-possessed. And I said to my husband, take the baby. His eyes are glowing. I think he's demon-possessed. And then she said to me, Bertie, I don't think that's a normal thought, is it? No. Do you hear that's not a what-if intrusive thought? That's not, we don't have an intrusive thought that says, what if my baby's demon-possessed? That is a psychotic thought that says, I see my baby's eyes glowing, and I think he's demon-possessed. As many as 80% of people give an incorrect diagnosis with OCD. So we have OCD support groups where they can really just not feel alone. So PTSD in childbirth. It's in the eye of the beholder. It is an event occurring during labor and delivery process that can involve actual or threatened serious injury or death of the mother or her infant or the woman being stripped of her dignity. Birth trauma can be both psychological and physical. These are potentially traumatic perinatal events. Okay, look at all of these. You know all of these. This is not the woman who's been in labor for hours and finally somebody comes in, the OB comes in and says, listen, this isn't working. I think we need to do a C-section. She usually says, that's fine, I'm exhausted. She signs consent. Now, she's still disappointed that she had a C-section, but this isn't PTSD. PTSD is when we're running and screaming down the hall after baby has a D-cell, and we're all screaming, get the OR ready. We got to get this baby out. This baby's heart rate's dropping. She has PTSD hearing she might die, the baby might die. And look at all these others. Hyperemesis gravidarum, 24/7 vomiting through pregnancy. As soon as the baby's born, the vomiting stops. She's got PTSD from that pregnancy because no one believed her. They all said, oh yeah, it's morning sickness. No, it's more than morning sickness. And don't tell me, have you tried saltines? It's not. That's not what it's for. And all of these others, just imagine, traumatic vaginal birth. Nobody expected baby to go to NICU. So Cheryl Beck found 4 themes that were common in those who had a traumatic birth. 1, I felt abandoned. You stripped me of my dignity. You didn't support me or reassure me. Women tell me they felt violated. They felt raped. You did things to my body without asking. Poor communication. I kept asking you questions and no one would answer me. Now again, this is if you have a doula in the room, the doula is explaining what's going on. Whereas the partner and the actual birthing person doesn't have a clue what's going on. Feelings of powerlessness, you betrayed my trust, you didn't protect me. And 4, when it's all over, did you really have to do all that to me? They don't come in for their postpartum check, they won't go back to the same hospital, they won't go back to the same OB, they're very angry. And if they do go back and they try to ask about it, many times they don't get confirmation that it was traumatic. They don't get, and even they'll ask to see their labor and delivery notes, and when they look, they always say to me, Bertie, it wasn't nearly. There was nothing on those notes that made it look like as awful as my birth was. They need therapy, and they need therapy with someone who's going to help them to recover from that traumatic birth, and especially if they choose to have another birth in the future, they really need to go through that, because otherwise, when they come in to have their next birth and they never resolve the last one, they're going to go into panic attack. Sometimes just walking in the front door of the hospital causes a panic attack. Latest numbers are really just showing, we have all kinds of numbers for PTSD, but the latest I saw is 1 in 2 women report that something was traumatic about their birth. 1 in 3 women have been sexually abused. 1 in 3. And what if they come in to have a delivery? We are touching them, put our hands inside of them, touching their breasts. It triggers their body back to the former traumatic sexual assault. Sometimes they dissociated when it happened, and now it flashes back, and they're really confused about what's going on and what happened. I know a woman who just started screaming during a emergent C-section because she flashed back to when she was held down and sexually abused, and we don't know any of that till afterwards. They dissociate, their body remembers. So this is a great training called When Survivors Give Birth. It's a 2-day training. It's also a book. And it tells you how should you deal with anyone who's in the birth work field should be reading When Survivors Give Birth. Because if 1 in 3 women that you're seeing has been sexually abused and they're coming in to be treated during pregnancy and postpartum, we need to know more about it. Just assume that any parent that has a baby in the NICU has PTSD, both parents. This is not what we dreamed of. This is not what we expected. With traumatic birth, with PTSD, with all of this, when we get ready to plan that baby's first birthday party, we flash back to that delivery all over again. Here are great websites, and PSI has birth trauma support groups. Wendy talked about maternal mortality, and you'd had to have been under a rock to know that the maternal mortality rates, especially in Indiana, we're in the top 10 worst. PSI has a group called Maternal Near Miss, and this is someone who almost died during delivery, could still die, such as cardiomyopathy, having a stroke, having a heart attack, having a amniotic fluid embolism. So this is a unique group for them. Wendy also mentioned about the high Black maternal mortality rate, higher in Black populations, in indigenous populations, higher in with infant mortality, same. Bipolar, we're not going into all about how to diagnose bipolar, but just know that it's a chronic disease, takes years to get a proper diagnosis. It's the highest risk for psychosis. What happens is they'll come in after a manic phase where they are up for a week. They come in, they've crashed, they're depressed. We don't ask enough questions. We put them on an antidepressant and put them into mania. And then we go, uh-oh, that was bipolar. They get misdiagnosed a lot. We have bipolar 1 and bipolar 2, and that's called soft bipolar, and it can really be overlooked. 20 to 30% of women with known bipolar go on to get psychosis, so we really should be watched closely by a psychiatric care provider all through pregnancy and the first year postpartum. We have groups for bipolar support. Most of our groups are led by those with lived experience, and some of our groups like bipolar and psychosis also have a therapist that's well-versed in that area, also co-facilitate. So we have groups both in English and Spanish. Psychosis. I pretended I was delighted in order not to make other people alarmed, but I was steadily getting worse and soon resented having to change and feed Elizabeth. A deep male voice started talking to me, coming to me at times I couldn't predict. He told me I was so bad at being a mom that Elizabeth would be better off if I were dead. The voice told me Elizabeth was sent by the devil. Then when I went to fantasize about hurting her, I knew it was time to seek help. You hear the mixed messages there with psychosis, waxing and waning, as Wendy mentioned. She's hearing voices telling her to harm herself, she's not a good mom, harm the baby, and yet she said, I knew it was time to seek help. So she doesn't get asked the right questions, they're not going to realize this is waxing and waning of psychosis. And then the psychotic break happens, and that's when we hear the horrible stories. 1 to 2 women in 1,000 will develop psychosis. Women experiencing psychosis are at higher risk of harming themselves or their babies, but keep in mind, 1 to 2 in 1,000, which isn't rare, and then of those, a very small amount are dying by suicide or committing infanticide. So it's not like everyone who gets psychosis goes on to commit infanticide or suicide. So we kind of have this mixed up. Now, it does take longer for recovery. I will tell you that. The recovery is longer and they need help at home once they get out of the hospital. It is a medical emergency. They need to be hospitalized. These are risk factors: previous bipolar psychosis or postpartum psychosis, family history of bipolar or postpartum psychosis, sleep deprivation. You go without sleep, you too can go into psychosis. Go a week without sleep. So we've got to protect sleep with bipolar disorder and a history of psychosis. Onset's usually in the first 2 days to the first couple of weeks. They are rambling, they are tangential, they are paranoid, they are think that you can hear their thoughts, they think the television is giving them messages, flight of ideas, hallucinations, delusions, grandiosity, think they're on the same level as God and angels. Women with bipolar disorder should remain on medication, and there are some people that only get psychosis in the postpartum period and at no other time in their life, and some women are diagnosed with bipolar disorder for the first time postpartum. This is a great resource for psychosis. Actually, you want to get anyone who had psychosis hooked up with those who also had psychosis because they feel so alone, just like any of our groups. Last Friday was the first Friday in May, and it was Pregnancy and Postpartum Psychosis Awareness Day. We have psychosis coordinators, and you want to hook them up with our coordinators. And we have a task force. We have online support groups for psychosis and survivors' families. Okay, let's look at the dads. This is our own Daniel Singley, one of the dads trainers, and he's got a t-shirt that said, "Dads don't babysit, it's called parenting." We have dads groups, we have dads support groups, we have chat with an expert for dads. Many studies now that we have done over and over, studies show 10%, no matter where, look at this, all over the world, 10% of dads get postpartum depression, anxiety. They look different. It spikes between 3 to 6 months. Rather than sadness, they're irritable. They go to their man cave, they play video games. They check out, they come home later and later from work. They feel burdened, they feel trapped, they feel financial responsibility, and you know what? They feel outside the circle of attention. And this same thing, it happens in a same-sex relationship. Remember, it's all about the pregnant person, then it's all about the baby, the pregnant person is second. The partner's thrown way out of the picture. This partner or dad misses sex, misses their birthing person, and yet they're also sleep deprived. So it's a whole thing. They just feel lonely. We have a 2-day training called Foundations in Paternal Perinatal Mental Health. It's a great training. So single moms, even higher risk, high, and they're afraid to mention it because they're afraid you're going to take their baby away. They feel lots more vulnerable. Dads, single fathers, had a higher 3 times mortality rate of single mothers, likely due to binge drinking, hypertension, and risk-taking behaviors. We don't have lots of research around queer communities, but what we do know is higher perinatal mood disorder rates, fewer resources, and we don't even keep track of who is in a queer relationship. So we don't even have great stats on it. We do know that lesbian women in the postpartum period reported a higher prevalence of a perinatal mood disorder and rates of attempting suicide. Gay male parents, same thing. Listen, overnight they lose all their freedom, all control of their schedule, and they don't know what they're doing. So why would we assume that they wouldn't also get a perinatal mood disorder? And yet they chose this. They used a surrogate. They adopted. And so we don't expect anyone to say, I'm pretty overwhelmed. I'm not crazy about this. No, you're not allowed to say that. The non-gestational parents may have a sense of jealousy, so let's remember, we're barely checking on the mom or the birthing person. Let's remember to check on partners. Now, we ask, who gets this and why? Why did you keep talking about risk factors? So you're not alone. This affects 1 in 5 to 7 women, 1 in 10 men. You're not to blame. It's not your fault. You know why we get a perinatal mood disorder? Because you had a previous perinatal mood disorder, you started getting symptoms in pregnancy and you weren't treated. It's going to go right into postpartum. Any of the things I just talked about, depression, anxiety, OCD, PTSD, bipolar, psychosis, substance use disorder, eating disorders. You yourself, personal history, or family history. These are our hugest risk factors. You were a moody teenager, you're really irritable and rageful before periods, you are really affected hormonally by any kind of birth control or hormone changes. Risk factors, evidence-based risk factors, thyroid imbalance, endocrine disorders such as PCOS, decreased fertility, fertility medications, that entire infertility roller coaster for years, diabetes. Do you hear risk factors that you can't change? You have these. You click off your own risk factors right now. When I teach this in childbirth ed class, in my 4th trimester class, I want people to say, wow, I should be watching for this. I've got a lot of these risk factors. Inadequate social support, interpersonal violence, financial stress, poverty, recent loss or move. Military families, teen parents, parents of multiples, single parents, Black and Indigenous families, and temperament of baby. These are all higher risk than even 1 in 5 to 7. If a baby screams all the time, that is a really high risk factor, and we have to give examples for how they put the baby in the crib, make sure they're safe, and walk outside. You cannot take a baby screaming for 2 hours. Complications during the pregnancy, the birth, or breastfeeding. You are a teenager or you're in your 40s and you got those hormones mixed up with pregnancy and postpartum hormones. Seasonal affective disorder. We just lived through winter again. It is spring, y'all. It is spring, and we have made it. We can put away the happy light now until fall. I just saw when I was here this morning, coming on the way here, that your lilac bushes are blooming, and mine are already gone. Isn't that funny? Just 2 hours north of me, mine are gone already, and I just wanted to say, hey, hold on, Uber driver, pull over. I want to smell that lilac bush. Perfectionism, pain, lack of sleep, abruptly discontinuing breastfeeding crashes down good hormones. If someone's going to stop breastfeeding, have them do it over a slow 2 to 3 week period. Sexual abuse, any previous losses. Relationship with your mother died, your mother's in another country, your mother abandoned you, neglected you, abused you, you and your mother haven't spoken in 5 years, you and your mother argue all the time. When I have a baby, my mother issue, they come up. Always rule out other causes. Wendy showed you this cool thing. You can use this to teach with. If 6 to 8% of pregnant people get gestational hypertension, 6 to 8 diabetes, 6% preeclampsia. We screen everyone for these things in pregnancy, but we're not screening everyone, and it's a 21% get a perinatal mood disorder. The 2 most common screening tools, and we have a class, postpartum planning class, that's free, so send your pregnant people there through PSI. I do a 4th trimester class, and I just want to, because it's almost time to be done, and so I want to, you cannot tell by looking, we need to screen. We know who's at risk, we know how to screen, we know how to help them. So we're going to do it everywhere. No matter if you cross the path of a pregnant or postpartum person, I want you screening, talking, educating. Discussion tool, Wendy showed you that. It's a great tool just to hand out because they can take it home and look at the risk factors. They can look at signs and symptoms, and it's got a link to our helpline and to our support groups. How do we get them better? By medical evaluation, possible medication, by therapy possibly, and social support. I will tell you, for over years and years, women will say, I'm glad I took medication. I'm glad I saw a therapist. But if I hadn't had my support group, I wouldn't have made it. Support groups are so important, and we have over 40 a week in English and 24 in Spanish. They also need new parent classes because they don't know anything. You are not alone. You are not to blame, and with the proper treatment, you will be well. When we're not treating them, we're affecting them, the baby, their pregnancy, the outcome of the pregnancy. We have to help them make choices with breastfeeding, but if they want to breastfeed, please get them all the help they need. Get them to the resources. If they want to stop, bless them, and let them stop without judgment or guilt. Now, resources. Wendy gave some of them. I'm going to go over them, and I'm going to tell you what's right here in Indiana. We have an app on PSI. There's the helpline. There's the hotline. We have coordinators in every state. So we have PSI coordinators, volunteer coordinators in the state of Indiana who will help you know what to do with someone. They know the resources, they know where they are. Was a support coordinator for Indiana for 23 years, so I know what they do. We have specialized coordinators. We may not have a group for something, but we might have a specialized coordinator. We have coordinators in over 40 countries. We have chapters. We have a PSI Indiana chapter. Please, who's in the chapter in here? Anybody? They're in another session or out running around. Please join the chapter. Be with them and help in the state. We have the directory, psidirectory.com, where you can find people right here in Indiana who are trained. You cannot be on our directory without having basic foundational 14-hour training. We have an access line, which I heard Wendy also mention. It's CHAMP. Support for parents. We have all kinds of things. We have peer support. We have closed Facebook group for moms, for dads, for loss. We have all of our zillions of support groups every week. We have chat with an expert. We have Smart Patients Forum. We have medical provider training, which is just a 4.5-hour training, recorded or in person 6 hours, just an overview of perinatal mood disorders, followed by how do I prescribe. So it's for prescribers. This is our psychiatric consult line, so your OB care provider says, I'm not sure what to do. They can call, they can make an appointment, and they can talk with one of our reproductive psychiatrists who will talk to them for free. Or they can call Indiana Access Line also, do the same thing. Perinatal Mental Health Alliance for People of Color, Blue Dot Project, we have a legal justice program, we have posters, we have flyers, we have all kinds of, we have DVDs, one in English, Spanish, we're on everything social media. Follow us, you'll find some good stuff, both in Spanish and English. We have little short video clips that are really great for educational purposes. Go in our bookstore, it tells you good books for you and for your patients. We have trainings, okay? Any kind of training you can imagine. We have a 2-day loss training that is amazing if you're working with perinatal loss at all. We have the dad's training. I have a PMH 101 training that I do quarterly, and it's similar to what I just did, but and I talk just as fast on that one. We also have a perinatal substance use disorder 101 free quarterly. Please watch this. It's very good. And we also now have an all-day perinatal substance use disorder training. But this is free, 90 minutes. You want to see it. We're going to New Orleans for our annual conference. Come join us. Come join us and volunteer. Here is your Indiana Board of Directors for the PSI chapter here, right here in Indiana. And we actually, the board, the PSI chapter has gotten money 3 years in a row from the Colts Kick the Stigma campaign. They've given us $20,000 3 years in a row to send people for free, giving out scholarships. So get a scholarship to go to trainings, and they're getting ready to do something else with us here coming up. We're doing a media thing that I'm going to talk at. I'm going to be on a panel. Get involved with fundraisers. Here's our support groups in Indiana. So you can go on our websites, on our Facebook page for the chapter and find all the groups. Of course, we've got right here in Fort Wayne with Jennifer, and then we have them all around the state, a lot of the hospitals. And I just found out recently, near Evansville, they just opened the first intensive outpatient program in Indiana. I never thought it would come out in near Evansville, but it did. I always thought I would have the first one, but it's down by Evansville, Newburgh, Indiana. I had to look it up, and I'm like, oh, there it is. They have an IOP, and it's virtual. So anyone in Indiana, you can send your patients to an IOP. We have nurse-family partnership, healthy families, all kinds of cool things, which I'm assuming some of the, there's some of them are out there. And look at me, 1 minute to go. You are not alone, you are not to blame, and with the proper treatment, you will be well. And I left no time for questions, so if you have them, you're going to have to email me or come up and ask me. So I'm so glad you all came so that we can keep getting the word out about this. So thanks. Thanks for having me, Jennifer.
Before today, who had seen Birdie? Who has seen Oh my goodness. Okay. Yay. Now you all know Birdie. You're in this circle of maternal mental health in Indiana. All right. So we are setting up for lunch in the gymnasium. So if you guys want to go head over there, we'll have lunch and a panel discussion about practical professionals. So we'll meet back here after lunch. Great. Great job. Okay, everybody. Thank you for joining us for the afternoon breakout session. I hope you guys are having a good day. Is everybody having a good day? Are we learning something? Meeting people? Okay, that's what it's all about. I'm super excited to introduce Delaney Bowman to you. She is the mastermind behind Made to Thrive Mental Health Wellness. And just a wonderful, amazing resource in our community as a nurse practitioner and prescriber and maternal mental health advocate and family advocate. So I am very pleased to welcome Delaney.
Hello, good afternoon. Thanks, Jen, so much for the opportunity to speak today on a topic that is just so important. So I can kind of read the room. Prescribers, can you raise your hands for me? All right. Ashley, right? Hi. Therapists? Perfect. Doulas? Okay. What else? What did I miss? Pharmacists, social workers, nurses, of course. My team. Okay, nurses. Wonderful. I'm so glad that you're here. Oftentimes in maternal mental health, our own personal experiences are kind of what have driven us to a place of doing this work. So I just want to affirm you in that and affirm you in your decision to honor the call that is serving women during pregnancy and postpartum. So as Jen said, my name is Delaney Bowman. I am a family and psychiatric nurse practitioner. I also hold a perinatal mental health certification through Postpartum Support International, and I am the owner of Made to Thrive Mental Health Wellness, and my focus is on medication management in pregnancy and postpartum. I ideally see patients before they're becoming pregnant, so we can talk about the medications that they're currently on and make that the most ideal, medication regimen. But as many of you know, that rarely happens. So, with regards to kind of the things that brought me into this work, my own kind of personal experiences with the births of my children and my postpartum experiences, as well as I experienced the stillbirth of my daughter, Rowan, and within that, operate a nonprofit organization that pays for infant funerals in Indiana. And so this just very nicely kind of jives with the experiences, both personally and professionally, that I have. So what we're going to talk about today, we're going to do a review of perinatal mood and anxiety disorders, discuss screening recommendations, and review common myths associated with psychopharmacology in the perinatal period. So what are perinatal mood and anxiety disorders? Perinatal is often a term that is kind of mixed up with prenatal, but that is the period of time from onset of pregnancy to up to 1 year postpartum. And kind of just building on or reviewing what Wendy talked about this morning, or if you weren't in Birdie's session, who I know did a deep dive into PMADs and kind of how those present, that looks a lot of different ways and can be a brand new onset for somebody during pregnancy or postpartum, but may also be something that they've already previously been experiencing that has exacerbation or sometimes even remission during pregnancy. So prevalence, we are looking at 1 in 5 will experience a perinatal mood or anxiety disorder. And for those that are therapists or are working, kind of in a family setting, always taking into consideration the presence of a PMAD in a father is important too. We know that affects 1 in 10 dads. The graph shows the pregnancy-related deaths, and I just want to, again, further build on the data that Wendy shared earlier and just really just point out that mental health is really at the forefront of these deaths that we are seeing. And we think about the big, scary things that can happen in postpartum hemorrhage, amniotic fluid embolism, cardiomyopathy, these big eclampsia, big scary things that we kind of prepare for postpartum, but we're really missing the big picture here when we're not taking into consideration mental health as a big cause. PMADs do not discriminate, and socioeconomic status is not a protective factor. So we think about these two famous women, Hayden Panettiere and Serena Williams, who both very publicly shared about their experiences with postpartum depression and postpartum anxiety, which led to Hayden Panettiere's substance abuse and her being very upfront about her alcohol addiction. Some cultural considerations. We know data shows us that postpartum depression is experienced across all cultures. And because our data is not further stratified between certain cultures, it's difficult for us to differentiate exactly what the rates are, but we do know that that is kind of a global experience. Taking into consideration, especially, locally, our, the cultural makeup here with Burmese and Amish population and just how some of these mental health conditions may present looks very different than kind of what we may expect or what we're trained to kind of think about or what we may personally have experienced. So just using that lens to kind of bear in mind that this may not present the way that we expect. With regards to the importance of screening, Postpartum Support International talks about their kind of screening guidelines and when we should be instituting those, and those are laid out on the slide here. But recommendations for evidence-based screenings, the Edinburgh Postpartum Depression Screen, as well as PHQ-9 can be utilized. And, we know that ideally a provider that is kind of staying with their mom during the duration of their pregnancy and into postpartum, sometimes those, just like physically how that mom may look after birth, it's very helpful to have somebody that has been consistently seeing the client or the patient through her pregnancy, and that may be kind of the first sign that something's not right. So making sure that, if you are currently working in an OB clinic that isn't screening, please bring this evidence, bring this recommendation to your clinical supervisor, your OBGYN midwife staff, because we know that we can identify these clients during pregnancy. That gives us a better idea of kind of what their postpartum planning might look like. If you think about, medically, the things that we screen for during pregnancy, preeclampsia, gestational diabetes, urinary tract infections, all of those are at rates between 8 and 12% that we're finding during pregnancy. But we know that PMADs are occurring 1 in every 5. So at much greater percentages, PMADs are present. So it is it's as important as screening for these medical conditions. A little bit on etiology and kind of risk factors. We know that this is kind of multifactorial. There may be, genetic risk factors. There may also be some clinical things that could potentially increase the risk of production of a PMAD. So things like PCOS, hypothyroidism, and other things like I often will ask particularly about, what was your mood when you were going through puberty? And do you have fluctuations in your mood related to your menstrual cycle that, the luteal phase, the last 2 weeks of your menstrual cycle, you're anxious, you're depressed, maybe you have intrusive thoughts, maybe you're angry and irritable. We know that they are going to be at higher risk of developing a PMAD because they do show some hormonal sensitivity, and that really has a big impact on their mood. Psychosocial risk factors, there's a million of them, but intimate partner violence, single mom, poor support, childcare issues, breastfeeding issues, birth trauma, baby in the NICU. I could go on and on and on. One that I tend to kind of see recurrently is a type A, high-achieving woman has her first baby, and it can be really challenging. I see that dynamic a lot. And so just, knowing that like perfectionism is kind of a risk factor, just being aware of that and being able to affirm and validate that for them too. All right, so moving into our myth number 1, the only risk in perinatal mental health is exposing the fetus to a medication. So the age-old traditional medicine model tells us risk versus benefit, right? Risk of medication, risk of intervention, risk of surgical procedure outweighing the benefit. That's kind of the scale that we use. But I flip that when I'm talking to my patients, and I say that there's risks both sides here. There's risk of medication exposure to the fetus, but we also know data shows us that there is risk of untreated mental health condition and that exposure to the fetus as well. So that data has showed us that there is increased risk of preterm birth, increased risk of low birth weight, and increased risk of preeclampsia development in a mom with untreated perinatal mood and anxiety disorder. So you think about eventually what does that kind of look like as far as impact goes? That can impact attachment, that can impact their postpartum experience, maybe they're over anxious. Additionally, studies have shown, there was one study that showed that there was an epigenetic link with increased exposure to cortisol to the fetus in utero can potentially lead to some emotional dysregulation as an infant. So there needs to be more research done, but like physiologically in my brain, that makes sense. If there's excessive cortisol that mom is kind of putting out as a result of this anxiety, that there isn't anything that's going to prevent that exposure to the fetus. One thing that I often feel like is missed in this discussion, and it's my last bullet point here, I'm jumping ahead a little bit, but is the quality of life for the mom. I think that we forget about that in the discussion, that this, she does not have to be miserable. But of course, these untreated mood and anxiety disorders can lead to self-medication, alcohol abuse, substance use, suicidality, increased risk of suicide. There's discord in their relationship with their partner. There can be job loss, and then just like disconnection from this infant that we know how important that initial attachment is. So let's talk about risk of medication exposure. So this is predominantly with serotonergic medications. There is a syndrome called neonatal adaptation syndrome. And essentially what this is and how I try to explain it to my clients without using the word withdrawal, because that feels big and scary. I generally say when the baby is still in your belly, there is a small amount of exposure to the medication. After birth, they're now no longer being exposed to that medication. In about 30% of infants that are exposed to serotonergic medications, they may experience this neonatal adaptation syndrome. And that kind of looks like they might have increased muscle tone, they might have decreased muscle tone, they might be jittery, maybe a little bit more difficult to feed. Sometimes they can have some transient tachypnea or rapid breathing. This generally resolves between 36 and 48 hours after birth. This is quick, it's transient, it goes away, does not generally warrant a NICU admission. But is a part of this kind of education and information that you really need to be providing to your patients. So that's the first risk. The second risk is something called persistent pulmonary hypertension of the newborn. And how I present this to my patients is PPNH occurs in approximately 2 out of every 1,000 live births naturally. And we think that serotonergic medication exposure in utero increases that risk at most to 2.9 out of every 1,000 live births. So not even one full additional live birth that is, potentially going to experience this. But again, a part of the discussion, informed consent on what the risks are. So I think an important talking point here, just overall and with statistics, is, you could easily say, well, you have a 48% increased risk of having a baby with persistent pulmonary hypertension. But when we break it down to absolute risk here, the risk is, again, not significant. Myth number 2, insert SSRI/boost bar here is the safest medication in pregnancy, okay? So the safest option is in a mom that is stable on a medication, the safest option is the medication that she is presently taking. Switching to something that's safer, like Lexapro or Zoloft, and a mom that's stable on Prozac is really unnecessary, and we potentially risk relapse. Of course, if we are in the midst of a pregnancy and we have an option, then yes, we're definitely going to choose something that has a lot of really well-studied data and gives us a lot of peace of mind with regards to that safety. But discontinuation is unlikely to be the best option. Myth number 3, if a mom is stable, psychotropic medication should be stopped during pregnancy. Again, discontinuation is unlikely to be the correct option here, but it is a very specific, conversation, individualized conversation about the absolute risk with serotonergic medication exposure, and also just talking about, her particular history. Has she had a history of postpartum depression? Was she hospitalized last year for a depressive episode with suicidal ideation? Kind of what does that individualized plan look like? But also pointing out and providing them with, the best education so they can have informed consent and be empowered to make that decision is absolutely necessary. Antipsychotics and mood stabilizers are contraindicated in pregnancy. So antipsychotics we traditionally utilize for conditions such as bipolar disorder or schizophrenia. And we do have some very reassuring data as far as, a lot of these medications go and their exposure in pregnancy. So if we think about the risks of a mom who has a history of known bipolar disorder or a history of schizophrenia, we know that their risk of a postpartum psychosis is increased just purely because she has that history. So we have to bear in mind that we are trying to prevent a manic episode. We are trying to prevent a major depressive episode that leads to suicidal ideation. We are trying to maintain stability. So certainly if she is stable on the antipsychotic medications and we can, think about the potential risk postpartum, that is definitely what we need to do. Another consideration, and what I often see with patients that have, whether it's a bipolar diagnosis or a schizophrenia diagnosis, oftentimes they're on 2 medications. They can be on an antipsychotic medication as well as an antidepressant for their anxiety or their depression. And as a clinician, if you look at their medication list, let's say for a patient that has bipolar disorder, we're uncomfortable with them being on Abilify during pregnancy, but their Prozac, they feel okay about them staying on that. So the choice is ultimately to discontinue the Abilify and maintain on the Prozac. But the risk there is complete destabilization and that the SRI can potentially induce a manic episode. So I would certainly caution in those situations, if you have a client that has bipolar disorder or schizophrenia, I would really strongly encourage you to recommend that they are having their medications managed by somebody that is specifically trained. So one, we can make sure that there isn't a postpartum psychosis postpartum, but also just so they have, the information and the education, and everybody feels comfortable about that. So I know that in a lot of OBGYN and midwife clinics, there is just not a lot of comfortability utilizing these medications. And so finding an appropriate clinician that feels comfortable in having those discussions with the client is important. Again, in these situations, rarely do we have the time where somebody says, oh, I'm really desiring to get pregnant and I don't know if these medications are safe. Usually we're 6 weeks into a pregnancy and now having the discussion. But if you have a client that's in childbearing age and this is kind of a discussion that they're having with their significant other or they're thinking about, having an opportunity for them to have a preconception consult with regards to the medications that they're taking is really imperative. And I will speak specifically on Depakote on the next slide here. So when we think about second-generation antipsychotics in particular, many of them do come with metabolic considerations, those being increased risk of weight gain, as well as development of diabetes, hyperlipidemia. So bearing those, kind of changes in mind, that may potentially increase the risk for the client that is pregnant for a gestational diabetes diagnosis. So just kind of bear that in mind. Additionally, exposure to antipsychotics, there have been some studies that show maybe there's a potential for that the baby will be small for gestational age. So another kind of consideration with regards to exposure to those medications in pregnancy. With the exception of Depakote and lithium, there are no studies that show that there's potentially increased risk of miscarriage, stillbirth, birth defects with regards to the second generation or the antipsychotic exposure. So Depakote is really kind of the hard stop within the medication realm of a medication that we really do not want to expose the fetus to because there are known significant anomalies as well as learning disabilities that have been seen with fetal exposure to Depakote. Lithium, there is a slight increase of a cardiac malformation, and so that is one that is really a risk versus benefit. A lot of time when a patient is stable on lithium, that's not generally a patient that you want to destabilize, and in the middle of pregnancy, we don't want to risk that potential exposure. So lithium is one that we are okay maintaining on during pregnancy, but do recommend additional follow-up as far as anatomical cardiac evaluation during the pregnancy if there has been exposure to lithium during pregnancy. ADHD. My favorite. ADHD treatment is not necessary during pregnancy. ADHD has become quite a popular diagnosis. Thank you, TikTok. But for true ADHD, if any of you are ADHD sufferers, have children that suffer, have spouses or significant others that suffer, it can really be a pretty debilitating condition. So we are talking about a true ADHD diagnosis. There are a lot of risks with untreated or poorly treated ADHD within pregnancy. We know that can cause relationship discord, issues with work performance, being able to manage schedules at home, maintain home environment. And this is really just an individualized approach. We know that untreated ADHD potentially lends to increased risk of having a motor vehicle accident. If that's related to them seeking out substances or buying Adderall on the street, we have much better and safer options. So again, it's weighing that risk versus risk, but there are safe treatment options, and stimulants are a reasonable consideration for someone during pregnancy. With regards to stimulant and even some of the non-stimulants like Wellbutrin or Strattera that also work, predominantly on norepinephrine and dopamine, we do think about potentially an increased risk for high blood pressure, just kind of in the general population. So that would be something that we would certainly want to disclose to the client, and then also ensure that their OBGYN or midwife is aware of this, this medication may potentially be contributing to elevated blood pressure readings. Myth number 6, you shouldn't make medication dose adjustments during pregnancy. Plasma volume just naturally increases by over 40% during the duration of pregnancy. So naturally, that therapeutic level of whatever drug it is that they're taking is going to be lower. So if symptoms arise and they're now suddenly in the 3rd trimester and they're not well controlled, that's a consideration that we need to make, is just, potentially there's more fluid here, and because of that, we need to increase the dose. We think about drugs with very narrow therapeutic ranges like lithium. We know that, we are going to have to continue to closely monitor those levels in pregnancy. We may need to make dose adjustments and then quickly peel those off postpartum. Same with lamotrigine. Lamotrigine is one of my favorite medications of all time. But we know that increased estrogen, increases how quickly lamotrigine is metabolized, and so therefore exposure to increased estrogen, as we have during a pregnancy, can naturally reduce those levels of lamotrigine. Similar if they are taking combined oral contraceptive birth control pills. So bear that in mind. Something that's really of importance is to avoid this kind of gray area between risk versus risk. We don't want to end up in a position where we are both exposing the fetus to a medication while simultaneously exposing them to poorly controlled mental health conditions. So we really don't want to be in that gray area. So, all that to say, don't hesitate on potentially considering a dose increase in pregnancy. Supplements are safer options in pregnancy and breastfeeding. I see this a lot. Of course, we all want a more natural approach to treating whatever condition it is that we're trying to treat. But the bottom line here is there is very limited data with regards to the safety of medications in pregnancy and breastfeeding. We have much more robust data with regards to SSRIs and antipsychotics and even benzodiazepines in comparison to the supplement industry. So bear that in mind. Most mental health medications are not compatible with breastfeeding. The relative infant dose is kind of the number that we are looking for when we're making a decision on whether a medication is safe in breastfeeding. And the American Academy of Pediatrics has deemed that if less than 10% of the maternal level is passing through the breast milk, that's deemed a safe medication to take while breastfeeding. Over 90% of all pharmaceutical drugs have been shown to be under that 10% threshold. So, and that's not just in mental health, that's just kind of across the board. Of course, we would want to be mindful of, exposure based on the age of the infant, and then making sure that they're not excessively sleepy or having a difficult time feeding or any of those things if they are exposed to the medication. Another point is just to be mindful that some of these medications may change milk supply. So Abilify in particular can really turn off that prolactin, whereas olanzapine or Zyprexa, which is another medication in that class, will enhance or increase the milk supply. So bearing that in mind, medications like antihistamines or hydroxyzine can also diminish milk supply because they work on the histamine receptor. So options with regards to lactation and continuing medications, and there's really 3 of them. So the client could opt to stop breastfeeding and continue their medication and not risk the exposure to their baby. They can continue breastfeeding and risk the small exposure of the medication passing through the breast milk to the infant, or they can stop the medication and risk the potential recurrence or exposure of the perinatal mood and anxiety disorder to the baby. And myth number 9, all clinicians are educated on safe medication use in pregnancy and postpartum. This is like my last slam dunk, pretty easy one here. But I, in my experience in the realm of taking care of patients in this very vulnerable time in their lives. And as I reflect on my own experiences with my midwife, there is a unique bond that a patient has and a unique relationship that is built with the person that's walking you through this life stage. And oftentimes, I have had experiences where someone within the clinical realm prior to coming to see me had somebody that was misinformed give them misinformation. And I can tell you from experience, trying to unplant the seeds of doubt that have already been sown is really, really challenging. So my greatest recommendation for you, and I appreciate you coming in and hearing this important information today. If you are unsure on safety of a medication, please either find a resource that will give you adequate and correct information, or inform your client that I'm not sure, but I'm going to give you some resources, some people that are trained within this realm that can really help you. I have had clients come from psychiatrists that informed them that they needed to stop taking their medication at 35 weeks gestation to prevent all of the things after delivery, the potential, very small potential risks after delivery. I had a client last week who picked up her Zoloft from the pharmacy, and the pharmacist told her that it was not safe for her to take that during pregnancy. And fortunately, she was quite empowered and educated by her OBGYN, and told the pharmacist that he was absolutely wrong, and that that was the end of that conversation. I think she went back to her OB, and he made a phone call over to the pharmacy too. But misinformation will come from all sources, even those who believe that they are educated or are trying to be helpful. So a lot of what I would recommend for you is preparing your client for what they may experience in the real world. So that looks like you might read this on Reddit, or you might see this on TikTok, or your pharmacist might tell you that this isn't okay for you to take while you're breastfeeding, and your OB might say that they don't agree with us making a dose increase. But here is the evidence and the literature that supports why I think that this is safe and the best option for you. Here are just a handful of resources that are excellent. Obviously, Postpartum Support International has all kinds of excellent resources for not just pregnant and postpartum individuals, but also for clinicians. Massachusetts Gen usually does a perinatal psychopharmacology symposium. I think in the fall generally is when they do that. Mother to Baby has exceptional resources. You can just type in whatever medication it is, and it gives you a nice PDF that you can print out and give to your patient. It answers, top like 7 or 8 frequently asked questions about the medication and exposure during pregnancy and breastfeeding. And then IU Champ, I know Wendy spoke on that. I called them yesterday, or I put in a little request yesterday morning at like 9 a.m. and asked for a phone call yesterday at 1 o'clock when I had an opening in my schedule. And the psychiatrist called me back, lickety-split answered my question, and then I got a nice PDF emailed to me that had kind of a summary of our discussion and kind of what we talked about. So if you are a prescriber, it's a completely free service, and what an exceptional resource, especially in situations where you may not have a significant amount of time, or maybe psychiatry can't see a client for a couple of weeks, and you need to know now what is the best option for the patient. So if you are local and in this realm, I would love to connect with you and just find a way to be a resource. I see predominantly pregnant and postpartum clients through my practice, in person, virtually. For medication management, I take commercial Medicaid. So I would love to help and be a resource for your patients. So yeah, thank you so much. Does anybody have any questions? Yeah. Thank you very much. Yeah. Well, thank you so much again, and I look forward to networking and connecting with a lot of you.
All right, guys, so the other breakout is just wrapping up, and we are going to have our final keynote speaker in here. So if you want to hang out here, you're welcome to. We should be, maybe have about 5 more minutes or so before everyone else comes over. So yeah, hang out for a few minutes and we'll get ready. Hello? Okay, so we're going to go ahead and get started with our final keynote speaker today. Okay, so this is a huge honor to have Ilona Bannister here today. We were just talking about, she wrote her first book, can I use this? When I Ran Away, and released it like just when the world went into lockdown in 2020 in the pandemic. So I must have heard about it somewhere. It was about a mom who experienced postpartum depression. Read it yourself. It is the most beautifully written book from the perspective of a mom who is struggling to find herself after the birth of a child, after trauma in her life. It is a beautifully written book, and I cannot highly recommend it enough. So I'm just truly honored to have Ilana here. She came here from London. Yeah, we have some London in the house. She's going to be doing her writing workshop afterwards, which will be in the gymnasium, but I don't have words to say how much this book means to me, how much she means to me, so I'll stop talking and let her go with it. Thank you.
Hi, thank you so much for that introduction. Okay, I know you've had a very busy day, so we're just going to start with a show of hands. How many people in the room would describe themselves as a parent? Okay, great. How many people, no matter what your job is, would describe yourselves as professional? Professional, good, okay, nice. How many people in the room would describe themselves as a friend? Friend, lots of friends. Great. So I feel very safe in here. We have upstanding citizens, parents, professionals, friends. Okay, we're gonna take it up a notch. So if you said that you are a parent, how many of you would describe yourselves as a mama bear or a papa bear when it comes to your kids? Yes, don't be shy. I know you're there. Yeah, me too. Okay. And if you said you are a professional, then how many of you would raise your hand to say you're also a hard-working team player? Yes, lots of hard-working team players. Okay. And finally, if you're a friend, how many of you would say you're a loyal friend? Yeah, good. Okay, I feel even better. I feel very confident in here. We've got mama bears, hardworking team players, loyal friends. That feels like a really good room. Okay, we're gonna level up. Ready? Hands up if you said you were a parent, and you would also describe yourself as a fearless warrior who would go to any lengths for your children. Yep, okay. And if you said you were a professional and a hardworking team player, I don't want you to be shy about this. How many of you would say you are a complete and total badass at your job? Yes, okay, good. And hands up if you are friends, but you are actually ride or die soldiers for your friends. Yes, okay, that's what I thought. And now this is a room of people that no one is going to mess with, right? Fearless warriors, serious badasses, ride or die soldiers. Okay? Remember when you were parents, professionals, and friends? That was nice. But it's much different to be a fearless warrior, badass, ride or die soldier. And that's because words matter. And that may seem like a really basic thing to point out because we use words all day long, but sometimes we don't notice until someone says that thing that makes us stop, or says that thing that makes us laugh, or says that thing that makes us angry. We rarely stop to think about how much power words have until we hear something that hits us in a certain way. I'm Ilana. I'm a writer, as Jennifer said. I'm the author of 2 novels, When I Ran Away and Little Prisons, and I have another book coming out next year. I've been writing almost 10 years. I think about words all day long because that's my job. So I have to find different ways of putting words together on the page so that you, as the reader, actually feel something. Because my little words on a page have to compete against so many different other things that want your attention. Your phone, social media, other distractions. So I have to figure out how to get my words to grab you and keep you with me so that you turn the page. Words matter because even today, with all our technology and AI and Netflix, people still love books. Because even after all of this time and progress, words mean something to us. We like to hold them, we like to hear them and see them and feel them and hold them between the covers of a book. There's a reason why children love bedtime stories with their caregivers. That exchange of words is an expression of love. So what does this have to do with why we're here today? Mission Motherhood and our collective concerns about the well-being of mothers. Well, Jennifer reached out to me, like she said, when my book first came out, and she told me about Mission Motherhood, and I'm really moved by this collective concern and the work that all of you do and the support for new mothers, because that was really missing for me when I became a mother 14 years ago. The whole reason I became a writer was because of my experience with birth and motherhood. My search for support dealing with birth trauma and mental health problems, it was really hard to find. Unlike most writers, I had never dreamt of being a writer. I didn't major in English. I never had any intention of ever writing anything. I was a lawyer. I was always a big reader, but I never planned to be a writer. But becoming a mother and the struggles that I had forced me to leave my career in the law, and it all led me down a very different path. Words that were said to me along that path impacted the direction that I took. I grew up in New York City. I met my husband in New York. He's British. He's from London. He was working in the city at the time. We met, we got married, we moved back to London, and I became a lawyer there. I was working. We got pregnant, and I planned to do what almost everyone I knew was doing. I was going to take maternity leave. I was going to be a mom, go back to my job, and then keep going. My kids would be proud to have a mother who was a lawyer. They would go to school, I would go to work, we'd have dinner at night, we'd do homework, and life would move along. But things didn't work out that way. Each of us has a story that we tell about our lives. I want you to take a minute to think about your own life story. Are you the hero? Are there other heroes? Do you have a sidekick or a trusted companion? Do you have a nemesis, an enemy, a frenemy? Is there a villain? Have there been signs and omens in your life pointing you in a certain direction? Have you had brushes with strangers that you've never forgotten? Has someone shown you kindness and love, maybe hate? Have you overcome adversity? I'm sure you have. Are there words that people have said to you that you have never forgotten? In your motherhood or childhood chapter of your book, are you in a place of unicorns and rainbows, or are you on a ship that's being tossed in a storm? In my story, the motherhood chapter is where I walk into the deep, dark woods, and I will meet a fairy godmother and an adversary and a hero, and I will get a sign that eventually things would be different, and they would not go as I had planned, but they would be okay. Each mother that we meet, whether that's in your work with her as a professional, providing her with support, or whether she's your friend, or a mom you know at school, or your sibling, she has a chapter on motherhood that she will remember, because in most cases it's the most important, most pivotal one. And when we meet that mother, it's up to us to decide which character we're going to be in her story. Sometimes we might play a very important supporting role. Sometimes we may be her hero. Sometimes we may just make one fleeting, tiny cameo appearance in the background. But whatever interaction we have with her, the words we use with her matter, because she is going to remember them as part of her story when she tells this chapter, when she is old and looking back and remembering her life. I'm going to share some of my story with you to show you what I mean about the impact of words and the characters that mothers meet. That is me pregnant with my first son and my husband. And that is my son when he was about 4 months old. He's 14 now. There's one picture of me holding him in the hospital, but in the 4 months between these two photos, I couldn't find any other pictures of me. That is not surprising, given how I was feeling. After our birth experience, I didn't want to be in photos. I didn't want to be pictured. I didn't want to document how I felt at that time. Now, I'm sure you've heard many, many birth stories, so I'm not going to go into a lot of detail. But the most important fact about my labor was that it was 76 hours long. I didn't sleep very much. I didn't eat very much. I was 33. I was healthy. It was an uneventful pregnancy. My son was healthy. He just would not turn his head in the birth canal. And I should explain that in the UK, where we have socialized medicine, there's an emphasis on really pushing vaginal birth whenever it is possible in the best interest of the mother and child. So labors may go longer than what you might expect usually in the US, but even by those standards, 76 hours was a doozy. So given my very long, very painful labor, the first fairy godmother I encountered was a midwife called Sylvia. In the UK, obstetric care is led by midwives who are medically qualified, very highly trained. They work in hospitals alongside doctors. Doctors handle complex and high-risk births, and the midwives tend to take the more straightforward births. They coach every mother through her labor in the hospital, and of course, if a doctor is needed, then they're there right away. Sylvia was Filipina. She was about 4'11", but she was an absolute giant in spirit. She was larger than life. She stayed with me for about 12 hours, and her energy, her positivity, her enthusiasm never wavered. She supported me, she supported my husband, and while I don't remember very much of what actually happened, 14 years later, I do remember her smile, how she made me feel, and I remember her saying, "You can do it." 3 days later, I had an emergency C-section, and then we were put in a ward with 8 other women, all of their personal struggles and motherhood chapters unfolding behind the curtains that separated our beds. The baby stays with you at all times in the hospital in the UK, and that night my husband had to leave. So I was there, still numb, with a catheter, dazed, exhausted, and trying to take care of a newborn by myself through the night. This was unbelievably my view from my hospital window. That's the Houses of Parliament and Big Ben. And I remember looking up at Big Ben for the time so that I knew how long my baby was sleeping and when to feed. Finally, after 4 days and a surgery, I had started to doze off. Midwives have come around to do their rounds and their checks, and my baby was breathing too fast and he had a fever. And the doctor was called over, and now an important character enters my story, and some words that I have never forgotten. I was starting to crash from exhaustion, and I wasn't speaking very well, and I wasn't focusing, but I knew that the doctor who was dealing with my baby was very frustrated with me. I could feel it. And so finally she said, "The mother is incompetent. We're taking him to the NICU." Now, I was competent enough to understand those words, and I was competent enough to comprehend my baby was sick, and I was competent enough for those words to sear themselves on me so that even 14 years later, I remember them very clearly. In retrospect, I know she was doing what was the most important thing, taking care of my baby. I know it was the middle of the night. I'm sure she had her own family she was thinking about, her own life concerns. I'm sure she was exhausted. It's a busy city center hospital. I can only imagine that the pressure she was under was immense. But in my story, 2 things can be true at once. She was doing her job and saving my baby, and she also devastated me in the process. It would have been helpful in this part of the story if there had been a book of spells or a magic scroll that had some words on it that we could have used for a mother like me, who had labored for 3 days and had a surgery and then taken care of an infant through the night. Maybe words like mama bear or a fearless warrior who would go to any lengths for her child. I wonder how different my experience of new motherhood after a traumatic birth would have been if I had not received that word, but I had heard something different. The next morning, my husband was back. We went to the NICU with our baby, and the pediatrician was there. He was standing by the incubator. He was so young. I remember thinking he couldn't have even been 30 years old. He had dark hair and pale, pale skin, and I didn't have to say, I meant to say also, he had a very bookish, very British look about him. He looked really intelligent because he was also wearing these perfectly round black glasses. And I looked at my husband, and I didn't have to say a word because I knew what we were both thinking. Harry Potter had come to save our baby. He looked exactly like him. And so this is the part of the story where the hero enters. This doctor was gentle and sweet and kind and reassuring. My baby had a chest infection. He needed antibiotics. We were going to be in the hospital for a week. And that wasn't good news after what we had been through. But often in stories, there is also a sign, an omen, a premonition, a dream, a bird flying overhead, something that comes to tell the character what's going to happen. So when I looked up at Harry Potter and I saw his name badge, I saw that it said, Dr. Child. And I knew that this man had been born to do this work, and we were going to be okay. So those are the first few pages of the motherhood chapter of my own life story, and I'm sure that you have similar pages too. There was a fairy godmother, an adversary, a hero, a sign from above. Other words followed all those words too from my first days as a new mother. I had PTSD and postpartum issues. Sorry, I can't see all those words. I dealt with anxiety, rage at the change in my identity. I had another child. That was another equally difficult birth. I had had 2 emergency C-sections, so some words that were very common in the UK, like yummy mummy, felt very much like a status out of my reach. Another awful phrase, too posh to push, which is a joke that people would make when they heard you had a C-section. Very hurtful. There was also a whole other cast of characters that entered my story. There were other mothers. There was, of course, family. There was the pediatrician that I took my baby to see when he had a stomach virus at 9 months, who was on hold with the cable company on speakerphone while she spoke with us and told me to give my baby ice cream and potato chips. That is something that actually happened. We met lots of doctors because my baby was sick frequently, but today he is brilliant and strong and an amazing athlete. But it became clear to me that I wouldn't be able to go back to work as a lawyer the way that I once had. When my boys were 3 and 5, I tried. I took my continuing development classes, I applied for jobs, and I interviewed, but I was rejected. I was always second choice, despite being qualified to practice in 2 countries. I went to seminars for mothers returning to the law where a panelist actually told the room of highly qualified professional women that if they couldn't do the hours that the law required, they should go be paralegals or assistants because there was no space for us as mothers. That person was an adversary, not just of me, but of all mothers. In my interviews, I asked about flexibility for parents, whether I could work from home around my children's school functions. That was pre-COVID, and mothers just were not trusted to be able to work from home and handle their children. I even got a phone call from someone who had rejected me, who then called me to offer me the job when the person they hired instead of me did not show up to work. I looked at this now not as another adversary speaking to me, but as a sign. There was also the issue of the cost of childcare equaling my salary, which meant we would just be breaking even when I went back, which didn't seem to make a lot of sense to me, working just for the sake of work. I wanted to work, but I knew it wouldn't be what I used to do. So my husband suggested I take a writing class. I was very half-hearted about it. I knew the chances of being published were tiny, and even after being published, the chance of being successful at it was even smaller. And also, what would I write about? Well, it turns out lots of things. In my class, I had to turn in 5,000 words every month, and I was adamant that my kids would not be an excuse. I did everything I could to get those words in on time and to find ways to write around my children. After 10 months, I had the first draft of When I Ran Away. It turned out that words were very, very important to me. Words and writing helped me to process, to heal, and to express through fiction what I hadn't been able to say about my birth trauma and the loss of my career and the change in my identity and the anger at things not working out the way I had planned. Writing became the support I needed that I couldn't find. I was looking for a story like mine, where the woman doesn't go back to her pre-baby jeans and her pre-baby job and her pre-baby body, because that's not real. Because children change you forever, but somehow we're supposed to show our employers and our families and friends that we're exactly the same. They haven't changed us at all. Around that time, there was the idea of Prosecco o'clock that was very popular on Instagram. And in the UK, it was cool to have this bad mummy narrative, which was the opposite of the yummy mummy, someone who's just drinking gin and feeding kids chicken nuggets at every meal. Of course, that's not real either. Writing this book allowed me to say, I failed at going back to work, and I don't know why. My abdomen is shredded to pieces, and I can't find any clothes to wear. I'm drinking too much, actually, because these kids are stressing me out, and everyone else seems to know what to do except for me. I knew I couldn't be the only person who felt this way, who thought that I'm definitely not that perfect alpha mom, but I do actually care about broccoli, and why can't I get a job? When I Ran Away is the story of Gigi, an American woman with a British husband living in London, navigating postpartum depression and finding a way out on the other side. The book explores lots of different motherhood stories: adoption, infertility, the tug of war between working mothers and stay-at-home moms. It's about feeling lost while trying to take care of a baby. It's about not being sure if you're doing things right and not knowing who to ask if it's okay. It's about feeling sad that you've lost the woman you were before motherhood and trying to learn about the one that you become after. A funny thing happens when you write a book. Everyone you know pulls you aside and asks you if they're in it. And what's even funnier is that the people who are actually in it that you model the characters on don't recognize themselves, and they don't know it's actually them. The book came out at the start of COVID, and it debuted in the first week of lockdown in the UK. So it was very difficult to market it or get any publicity or any sales. So in sales terms, this book is not a success. In literary success terms, it's not a big bestseller. It's not a big successful book. But I did a lot of online talks, a lot of book clubs, podcasts, and that is when I started to really understand that the words we say to mothers really matter. Because in those book club meetings and in DMs I would get from women who were total strangers to me, they started to tell me about the motherhood chapters of their own life stories. They talked to me about their struggles, their triumphs, their isolation, their doubts, especially moving where the other older women of my mother's generation who had never had the opportunity to speak about their birth experiences. They had never felt supported enough to talk about the life and death struggle that is the birth of a child. In some book clubs, it was the first time that a woman had ever shared that she struggled as a new mother. And that is when I knew that no matter what the sales figures were or what the reach of the book was, to the women who read it, who heard themselves or saw on paper words they themselves had said or things that they had thought, those words were extremely important. Mothers remember those words. So to me, that will always be one of the most important things I've ever done. After When I Ran Away came my book, Little Prisons. Those are my kids there helping me out. My kids have watched me write. They've been involved. It's been good for them because they both have dyslexia, so understanding and seeing and being a part of books and how they're made has helped. And for me, there was healing and recovery and a new direction in life, learning how to pivot, but it was worth it because writing has allowed me to be at home with my children and support their learning needs. So it was not the career in law that I had planned, but it did work out for the best. But what I want to say at the end is that, we are not perfect. As professionals and parents and friends, we're not always going to say the right thing to a new mother. We're not always going to get it right. And we should also acknowledge that when someone is in a difficult or vulnerable place in their lives, they may hear or interpret our words in ways that we did not intend. That doctor was not trying to hurt me. And had she said the word incompetent to the woman I am today, she would have heard a lot of other words that I can't really say on the stage. But at that moment in time, that is how that hit me. Also, there will be other people in a mother's life, other characters who are going to play other roles in her story. It's not just you as one person. There is a whole cast of characters in that chapter. But while acknowledging that we're not going to get it right every time, one thing we can always do when we meet a woman in this chapter of her life is see that what she doesn't need more than anything is a fairy godmother or a hero, but more than anything, she needs kindness and empathy. We can make sure that we listen to her. We can be encouraging. We can be present. We can be non-judgmental. We can acknowledge her. We can be kind. We can remember a time when we were vulnerable and how scary it is to have to ask for help. Because when she tells the story of her life and she gets to this part where she is in the deep, dark woods, our kindness will be what she remembers the most. Dr. Maya Angelou's son, Guy Johnson, said that when people would ask him, "Did you grow up in her shadow?" he said, "No, I grew up in her light." That's saying the same thing with very different words, and they have a very different impact. All of our words are important, and they mean something to mothers. I'm just going to read you a quick few lines from here. This is the opening of the book where Gigi introduces herself. "Our beginning was a long time ago. Now there's a patch of my heart that's an open sore, like an ulcer pulsing on the ventricle, or the aorta, or whatever you call it. And now there's no heart left for the baby. I thought I could make room, but I can't. They took all the heart space I had, and now there's not enough. The pain is nothing new, the grief and shock and anger as familiar as my name. But when I became a mother, the pain multiplied and grew and stretched my skin and bent my back as far as it will go, because the pain a mother feels is not just hers. She feels everyone's pain. She picks it up for her kids. She carries it for the family. She takes it from her parents when they're too old to bear it. She cries when she sees crying mothers on the news. She tears up when she sees a kid in a wheelchair in the supermarket. She sobs when that Save the Children ad comes on. She has to leave the room when the old man's wife loses the baby and that's just a cartoon. Because more than the pain of the person who's hurting, she feels the pain of his mother, of all the mothers. They feel hers too. But what do I know? I know this. This is why it's hard to love me and hard for me to love, and why I love so hard when I do, because this is what I carry. And I urge all of us in this room to be the characters in a woman's life who help her to carry that load. Thank you so much for listening, and thank you so much for having me. Should I say a bit about the writing workshop? What time will that be?
I started it should be at 3.
Okay.
But we might be a little earlier.
Okay. If anyone's interested, I'm going to be doing some really simple writing exercises and a writing workshop that might be helpful for you to use as practitioners, for yourselves, or also with your clients. A lot of times, women get intimidated by writing. They think they can't do it, but there are really amazing ways of unlocking how you feel, and it can be really helpful. So if anyone's interested, we'll be doing that a bit later. Thank you so much for your time.
Thank you.
I don't know how to follow that. Thank you. All right, just let it soak in for a minute. Just thank you, everybody, for being here. Thank you, Ilona. Thank you, Wendy. Are you Wendy? See, there she is. Thank you, Wendy, Katie, Lauren, Katie, everybody, Stephanie. I'm going to start calling out people in here. Thank you guys so much for being here. We have another full day jam-packed tomorrow. We are really thrilled to be helping to educate and to bring awareness to women and to give space to everyone's experiences. And you all do such amazing work. It's just an honor to be able to bring this together for everybody to connect and learn and everything. So truly appreciate you all. If you'd like to go back to the vendor village and continue to mingle, feel free. That'll be until 3 o'clock, and then we'll do the workshop. If you are interested in CEUs, or if you came here for CEUs, there is a QR code on the registration table out there. Make sure that you sign in and sign out. I was told to say that they can't validate it if you don't sign in and out. We look forward to seeing you all tomorrow. If you have questions, we have Wendy here, we have Ilona here, we have our presenters as well. Please feel free to ask. But we look forward to seeing you all a little bit later or tomorrow. So thank you.